Good afternoon. Welcome back.
I would like to call upon our next chairpersons, Dr. Shyam Singh, Dr. Deepak Abrol, Dr. Srijan Shukla, and Dr. Shashank Mahajan, and Dr. George as our panelist.
Moderator, sorry. You come in front. Start.
We are now going to have a debate session on media channel staging, EBUS versus VAMLA. I would first like to call Dr. Amit Dhameja, who will speak his part on EBUS. Please give a big round of applause.
Well, good afternoon all of you, and hope you had a good lunch. Welcome back. I'm Dr. Amit Dhameja. I think I'm the only one of the two pulmonologists I see in the hall. Most of them are surgeons, but most of them are surgeon friends, so not to worry. I guess at the end of the talk, all of you are going to be on my side, so so today we're going to have a very interesting debate. It's not a debate. I'm going to present my side of the story, and Dr. Devyani is going to present hers. Because EBUS versus videostinoscopy is a no-brainer now. If you have EBUS and VAM, which is only videostinoscopy where you take punch biopsies, EBUS scores over and above as far as all the spheres are concerned. So what I'm going to discuss is how each and every aspect of it is covered. VAMLA is a different ballgame altogether. I guess very few centers in the country and very few surgeons in the country are actually practicing VAMLA. So it is going to be an eye-opener for me. I look forward to your talk, Dr. Devyani, and learn from you as well. So we're going to discuss EBUS versus VAM because VAMLA, I guess, is a has therapeutic potential. There are no head-to-head comparisons between EBUS and VAMLA, so we do not have any literature to quote. Where I come from, we don't do VAMLA. Where they come from, they don't do a good EBUS. So I think so what do the guidelines say as far as staging of NSCLC is concerned? The current guidelines recommend that the staging should start with EBUS TBNA and preferably combined with EUS TBNA as well, which is called a medical mediastinoscopy. The reported figures of specificity and positive predictive value are 100% or close to 100%. Very few, false positive will be there. Thus, positive results of EBUS TBNA do not require any further confirmation. Now, all of us would uniformly agree to that. If a patient has a positive EBUS, then you do not need to confirm it with anything. However, if there is a negative result on EBUS and you feel that the patient might be having mediastinal extension of the disease, whether it should be confirmed before surgery with VAM or we can actually proceed directly to resection is what we are going to discuss today. So let's see the points of comparison. If we are comparing two techniques, I will take a list of all these questions in my mind before we decide which one to choose from. So the availability of the procedure, operator proficiency. Now where I come from, Delhi NCR, I think we were the first to start in the last say 15-20 years. We have almost 50 centers doing EBUS. And despite 50 centers doing EBUS, our workload has not come down. So the work is growing, and there are more and more people doing EBUS. There are more and more postgraduates and DMs being trained in EBUS. And now there's no dearth of expertise as far as handling of the equipment is concerned, because most of us in our post-graduation or DM days are actually already trained. By the time we come out of it, most of us have done enough cases, that we are able to handle these patients individually at whichever centers we go to after passing out. So availability of the procedure, no doubt, there are very few centers practicing mediastinoscopy. EBUS is widespread. I guess Jammu has 3-4 centers now, Dr. Rahul?
Hello.
Okay. So operator proficiency is one thing. Whatever, everybody has the same machine. It's the man or the woman behind the machine which decides whether you'll get a good yield or not, whether you'll be successful in what you are trying or not. So skill, I think all the procedures, whether it is EBUS, whether it is VAM, whether it is VAMLA or TEMLA, all of them are going to be dependent on the man behind the machine. So make sure that you train yourself well. Where do we fail? When we do not follow the systematic pattern which we are supposed to when we're doing staging of the mediastinum. In fact, I was fortunate that I got this topic. I got to read about it after, say 1 or 2 years now. I saw many of the papers when you are reading, including the Medias trial, one of the trials which says that there's no need for a mediastinoscopy at all. How do they do EBUS? Now, they say that in Medias trial, they had 5 nodal stations, of which EBUS sampled only 2. Now, it is very, very odd. In case you have 5 lymph node stations, you should look for the 6th one and sample the 6th one too before you stop the procedure. They stop at doing only 2 lymph node stations, and that only 3 passes per station without a rose, in deciding that that's going to be the end of the staging procedure for the patient. And their premise is that in case the nodes are not more than 8 millimeters, now 8 millimeters in CT scan is no cutoff. World over, EBUS guidelines say any node more than 5 millimeters has to be sampled, even if it is a smaller node and the PET is showing some avidity, and even if it's a single station node, multiple nodes at same station, you sample each and every one of them before you actually say that the mediastinum is negative. So there are many fallacies as far as all these studies go. Couple of these studies did not have a good EBUS guy who was doing the procedure. Couple of them did not have a good surgeon who was doing the mediastinoscopy. So the results are going to be confounded by the proficiency of the person. So I would suggest do whatever you are best at. In case you have a good EBUS guy, let him do the procedure first. In case you have a good surgeon and you don't have an EBUS, at least do justice to the procedure. So availability of the procedure and operative proficiency goes without saying that they are the most important determinants of success or failure of a particular technique. Accessibility of the lymph nodes, again, of course, all of us are very well versed with the IACTS map. EBUS can practically sample each and every central nodes and nodes around the major airways, except for station 5 and 6, that is the subaortic and the para-aortic. So right from station 1, 2, 4, 7, 8, 9, 10, 11, you would not need to go further. So all of these nodes can be sampled very easily. In mediastinoscopy, you do not have access to so many of these nodes. And this is one of the papers from my dear friend Dr. Devyani's center itself, where they say that the accessibility of the nodes, you see EBUS has the highest yield, and in case you are able to combine EBUS and EUS, which we commonly do for most of our patients now, the yield is going to be very, very high, 93%, and the access to the nodes as far as all these techniques go are the best if you have EBUS and EUS combined. Mediastinoscopy and extended cervical mediastinoscopy, the access to the nodes are only central. With VAMLA you can go, I've seen a couple of videos going up to 10 and 11 as well, but somehow most of the papers talk about accessibility to 1, 2, 3, 4 and 7 only. And so as far as the accessibility of the nodes is concerned, EBUS and EUS combined give us the maximum access to the type of nodes or the number of nodes involved. Now, CT versus EBUS or CT versus mediastinoscopy, I don't think we're going to talk about that, but just for the interest of the audience, you see CT has a very poor sensitivity, very well said by Dr. George also. You should not depend on CT or a PET to say whether mediastinum is negative or positive. Even in the normal mediastinum, say nodes less than 1 centimeters, you will be able to pick up as much as 20% cases of malignant spillover. EBUS versus PET, again, the diagnostic accuracy is a mere 72%. 30% of the PET positive nodes are actually negative by EBUS. They can have a granulomatous disorder, they can have a post-fibrosis inflammation, post-radiotherapy inflammation, they can have anthracosis, which is very, very common in our country. Even in people who have never smoked, you see lots of black material coming from the lymph nodes. It is always PET avid because the inflammation is active over there. And just like CT, 10% of PET negative nodes are again positive by EBUS. So now we come to the accuracy. So as far as the accessibility of the nodes are concerned, EBUS and EUS score better than mediastinoscopy. Accuracy of staging tests, again, we are reaching a sensitivity of almost to the tune of about 90% with EBUS and EUS combined, where mediastinoscopy, the sensitivity is about 78% only. But that's not all. This is what the literature tells you. When we are doing the procedure, we do not look at only the nodes. We look at so many other things. We are doing the bronchoscopy also. So we do look at endobronchial inflammation. So rather than just doing a diagnostic test where you're doing it as a technician because somebody has said that there might be a node, you just go there blindly, pick the node and come out of it. You go as a clinician, you look at other things which are around you which will be helpful in decision making as far as that particular patient is concerned. Literature doesn't talk about this. So So I'll show you a couple of cases as to how EBUS is helpful in deciding the staging of a malignancy over and above diagnostic sampling from the nodes only. So endobronchial extension, all of us are aware, is bronchoscopy required? Yes, for any central lesion, a bronchoscopy is required to see the endobronchial component of the disease before we decide about surgery. Margins of the mass, involvement of the vessels by the lymph nodes as well as the mass, involvement of the adrenals, we can go up to the adrenals now, we can sample any metastasis in the liver with an EBUS and EUS together. You can even go to vertebral involvement. Sampling a vertebral involvement might be very difficult, but at least visualization of a vertebral involvement can be done using an EBUS and an EUS. So what are the EBUS signs of inoperability? Now on the left side of the screen you have a normal looking node, you have the cartilage, the mucosa, submucosa, adventitia, the tracheal, the bronchial tissue looks very, very healthy and normal. You have a very sharp border between the lymph node and the vessel. The vessel is not involved, and beyond that you see normal echoes of the lung. That's a classic, picture that you would get in a paratracheal lymph node station. On the right side of the screen on the top, I don't see the pointer working, but on the right side of the screen on the top, you see that the vessel is invaded by the lymph node. So there's no capsule in the vessel. The capsule of the vessel is invaded by the lymph node. The lymph node is actually invaded into the adjacent vessel. So this particular case is obviously not operable. Except for an MRI, no other investigation, including the CT or a PET, will be able to tell you in greater detail about invasion of surrounding structures, whether it is the adjacent bronchial mucosa, the mediastinal tissue, or the vessels. EBUS is definitely very, very helpful for you to understand the extension of the lymph nodes and the masses into various lesions as well. In the lower down picture also you see that the lymph node or the mass has invaded the tracheal and the bronchial wall also. You do not see the cartilage at all. You do not see the different structures that you expect in the tracheal or the bronchial wall. It has invaded the vessels, it has invaded the wall, it again becomes inoperable. You might stumble upon a tumor which is there in the vessel. Within EBUS you can actually sample vascular metastasis. This particular patient had a CA metastasis from CA breast 15 years after first presentation. This actually came as a pulmonary embolus to us. PET was positive. We sampled the pulmonary artery clot. This came out to be positive for malignancy. Another very important issue is restaging. In case you've done a mediastinoscopy in the first instance, in case the patient has undergone radiotherapy in first instance for the staging, for the treatment of the disease, restaging becomes impossible with a mediastinoscope or a surgical technique because you would not get plane, you would have adhesions, you would have fibrosis. It is going to be technically very, very difficult for you to get a plane to enter and to separate out tissues to do the justice of the procedure. As far as restaging with an EBUS is concerned, it is technically more difficult. It should be done only by experts, but it is doable. In case you are well trained, you should be able to do restaging of the mediastinum, and that is what we commonly do in a case where you have a neoadjuvant therapy. Patients comes back to us after 3 to 4 cycles, and we do, I'll just take 2 more minutes. And mediastinoscopy is practically impossible in these cases. And of course, the amount of tissue can be an issue. For that, we can do an EBUS biopsy now. Most of you would not be aware, EBUS evolved as a technique of an FNAC, but now you can drill a hole into it with a needle, with a cautery, depending on whatever equipment you have. You can actually pass a small forceps into the lymph node. You can pass a 1.1 millimeter cryoprobe into the lymph node and actually take tissues, 0.5 centimeter tissues from the lymph nodes, so that you are able to understand the architecture of the node vessel. Of course, most important for us as far as sarcoidosis and lymphomas are concerned, but also for restaging, we have had 3 cases in the last 1 month who had failed EBUS FNACs elsewhere, and of course we subjected them to lymph node biopsy. All 3 of them came out to be positive for malignancy. Other advantages: cost. We do it for about 30,000-40,000 rupees. Mediastinoscopy at our center would not cost less than 1.5 lakhs. Anesthesia, hospitalization required. Again, there's no question about that. It's a day care procedure. Light sedation, mild anesthesia. Patient goes back home the same day. There are no drains left in situ. There is hardly any complication. There are very many complications in case a mediastinoscopy is done by a not so expert person. The complication rate would be about 3 to 4% for mediastinoscopy. Most of them would have a recurrent laryngeal nerve involvement in case you are targeting the left-sided lymph nodes. So EBUS versus mediastinoscopy, after all this what I have said, is a no-brainer. EBUS scores better in all respects of comparison that we have talked about. Mediastinoscopy should reserve only for patients who are failures of EBUS. Medias trial, all of us have heard, we've had lots of criticism going around, but it told us that patients who have had a negative EBUS, you do mediastinoscopy first and then progress to surgery, or negative EBUS you take directly to surgery. The actual difference in the yield of an unforeseen N2 or N3 would be just 1%. So it might be an added cost to the patient. You might just add a couple of days of misery to the patient's life rather than operating upon the patient directly after EBUS. But again, this is again very early days. We need to have more data to say that a failed EBUS does not need a mediastinoscopy. A failed EBUS will still need a mediastinoscopy. This is only very few trials. One of the trials it says, but again, it had its own fallacies as far as their statistical model was concerned, as far as their distribution of patients who had an unforeseen N2 disease in each category was concerned. So there are a couple of confounding factors which we have to take into account before we decide whether mediastinoscopy is required or not. So I rest my case here, and thank you all for the patient hearing. I think I forgot one point. Give me a second. Yeah, here we come. We forgot about the patient's preference. Now, I put you all to friends and family test. Now, what we do is, in case I am the patient, or one of my close family members, or somebody very close to me is the patient, which particular test would lie up for myself and my family? I would love to have a raise of hands. If any one of you wants to get a staging procedure for one of your close friends or family members, how many of you would send the patient to me? Okay, I see the numbers going up.
Thank you very much. Well, nice to
Thank you so much.
And on behalf of chairperson, I would like to invite Dr. Devyani for her presentation.
Good afternoon, everyone, and Dr. Kohli, thank you very much for having me here. Dr. Dhamija, thank you for an excellent presentation and for laying the ground for what I have to say next. So I'm going to stand here in a crowd of surgeons, and even then, I think it is a big mandate for me to try and defend VAMLA. But Dr. Kohli made it easier because he labeled my talk as VAMLA instead of just mediastinoscopy. So why are we having this debate? Why are we taking 1 hour of post-lunch time for this discussion? The answer lies in this table and graph. Because 1 in 4 patients that we see with lung cancer have mediastinal adenopathy. And when they do, it dramatically affects their survival. It also affects the way we treat these patients, which is why knowing this is so very important. What is VAMLA? It is video-assisted mediastinoscopic lymphadenectomy. It is a very radical procedure. Starts with a small cervical incision. We put in a mediastinoscope, which is now a video mediastinoscope in most centers across the world. This scope goes anterior to the trachea, underneath the pretracheal fascia, and gives you a clearance of the upper and lower paratracheal and the subcarinal nodes at least. But with extended procedures, you can also get stations 5 and 6, which are traditionally blind spots for any invasive mediastinal staging. And the other stations that Dr. Dhamija talked about, the hilar and interlobar nodes, it's great if you can stage it, but it does not change my management in any way for that patient. What is the best modality for invasive mediastinal staging? As of today, I pitch EBUS plus EUSD with VAMLA. The sensitivity is a little lower for EBUS, negative predictive value of 96. VAMLA does slightly better in those fields, but as Dr. Dhamija very eloquently showed, EBUS is less invasive, no general anesthesia, fewer complications. So that's something that I cannot argue against. Little interesting snippet, the genesis of EBUS was 20 years back in 2004, with these great names who actually came up with the procedure, pitted it against a mediastinoscopy, which was called the gold standard. All of these are surgeons. So contrary to popular belief, we actually are on your side. Most of the guidelines say negative EBUS to a confirmatory need. Actually, I'm not convinced. So let's look at this paper by Bosima, which said that negative EBUS, they still had almost 10% patients having unforeseen N2. Most of these were micrometastatic disease, and it had no impact on the survival of these patients. In fact, their survival was equivalent to an N1. So what did we really do by picking up those extra 10% is the question that needs to be asked. This actually laid the basis for the MEDIAS trial that we spoke about. 360 patients, negative EBUS, randomized to mean or direct surgery. As Sir said, only 1% additional pickup with an additional procedure. You had to go through 11 to 24 patients to pick up this one patient who turned out mean positive but EBUS negative. So if we know all this, why are the guidelines so slow to adapt? The ESTS 2014, the NCC and ACCP, all of them still say negative EBUS, go with me. Probably because EBUS has certain shortcomings, especially if you're not a high volume center. So if you look at all the trials that give us impressive EBUS results today, they come from Toronto Gen, they come from Gangaram, Leuven, Heidelberg, all high volume centers doing excellent EBUS work. Is this reproducible for every other center is the question that is important. As any ultrasound procedure, it is operator dependent, and there is a learning curve involved not only for the person performing the procedure, but the pathologist as well. Let's come to the economics. If I have to set up an EBUS at Tata Memorial Hospital, it's going to cost me 1.5 to 2 crore getting in all the equipment. The procedure itself will cost 50,000 to 1.2 lakhs. And the personnel involved would be the pulmonologist or the surgeon in our hospital. Both of us do it, the anesthetist and the pathologist. Mediastinoscopy, the scope with the system costs 30 lakh rupees. It doesn't cost anything extra for the patient, but 1 to 2 hours of additional OR time, because we use frozen section to send the nodes for analysis and decide on curative resection right away. The only person required is the surgeon and the anesthetist who would have been there for the surgery anyway. Let's look at the time. Your patient gets diagnosed and staged, then you give him a date for EBUS, he goes to the pulmonologist, gets the fitness, gets the EBUS, comes back to you with the results, and then you schedule him for his definitive procedure, which is quite considerable. At midway through my talk, I say this is all semantics. As a surgeon, am I convinced that EBUS is a good staging procedure? Absolutely yes. Is there a need for confirmatory mediastinoscopy if I trust my EBUS person? Usually no. So that's my white flag. Let's be pragmatic. Real world data from Denmark, where all this data first came from. So if you look at the ESTS 2014 guidelines, which all of us need to be following today, even in Denmark, where it originated from, only 19% are actually adhering to these guidelines. So in India, where we have so many cost constraints to deal with, is it really reasonable to expect that the patient is going to spend twice the amount of money just for staging? So I think it's safe to say that at least do one. Whatever you have best resources for, either do an EBUS or do a MED. Let's look at neoadjuvant chemo IO. We spoke about multi-station 3 becoming, N2 becoming a surgeon's domain. When this is happening, are detecting these N2 nodes, is it still that important? We will know in the years to follow. So is there any place for VAMLA at all? Theoretically, it gives us increased nodal tissue because you're clearing the nodes completely. Coexisting granulomas sometimes may skew the EBUS results, but it will give you a definitive result when you clear it in toto. High level 2R, 2L is difficult to target with an EBUS scope, especially for novice EBUS users. Another advantage with VAMLA is it gives you an idea about the resectability of the nodes. Can the nodes be taken out R0, which is what decides whether you're going to subject the primary to surgery or to chemoradiation. But for me, this is what's most attractive. It is a one-stop shop. You get the patient on table, put him under anesthesia, do a VAMLA, send it for frozen section. Within 10 minutes, you know if it's positive or negative. If it's negative, under the same GA, you proceed with a curative resection. The nodal template has been cleared before you start the lung resection. So after you have done a particularly difficult lobectomy, at the fag end of the day, prior to lunch, you do not have to go back and do the lymphadenectomy. It has already been done. This becomes even more important in post-IO cases where the adhesions are so bad that you are relieved at the end of the delivery of the specimen that you do not need to go back and do a lymphadenectomy. It has already been done. Left-sided clearance is extremely good with a VAMLA because the entire nerve can be seen along its course at 10x magnification with a two-handed dissection. This is the kind of clearance that we can achieve with VAMLA. This is a case that we did just yesterday at the Tata Memorial. The left paratracheal, the nerve seen in all its glory, the subcarinal cleared with the esophagus at the base, and the right paratracheal with the azygos coming into view. Going one step further, courtesy to the Faculty of Medicine at the University of Barcelona, this is the scope passing above the arch of aorta, underneath the brachiocephalic vein, and you can also reach stations 5 and 6 to achieve a clearance. This video will not play, so I will go to the next one. At what cost? So coming to TMH data, from 2014 to 2024, in 10 years, we have done 658 VAMLAs for lung cancer. The specificity was 100%. The negative predictive value could have been better, but it was still 94.2%. It did come at a cost. We had almost a 10% left recurrent palsy rate. All of these were temporary and got better over time. We also had few episodes of bleeding, wound infection, and other complications like chylothorax. But what I want to stress here is that these complications are not associated with the staging part of the procedure. It is associated with clearing these lymph nodes. And those will happen anyway when you send your patient for a curative resection and they need to do an SMLND. So this can't be attributed just to the mediastinoscopy as a staging procedure. It is the therapeutic procedure which has caused these complications. In conclusion, I think what we are trying to do in this debate is compare apples versus oranges. We are trying to compare a staging procedure versus a therapeutic procedure, which makes no sense at this point in time. Let's look at the trends, and this is where as surgeons I think we need to be a little more careful. This was a survey amongst 98 thoracic surgeons. 87% of them were trained in EBUS. And I think that's what's happening today also, that most thoracic surgeons are trained in EBUS. 100% feel that EBUS training is a must. And 84% actually performed less mediastinoscopy after the advent of EBUS. This also happened here at the Tata Memorial, where the numbers of mediastinoscopy have been coming down as EBUS is getting better and better. But all of us need to stop and rethink this, because VAMLA is an excellent tool to achieve a good clearance, especially in the post-neoadjuvant chemo-IO setup, which is the reality of how lung cancer treatment is going to be over the next few years. So instead of these numbers going down, I think it's time that it showed an upward swing, because it is a skill that we cannot afford to lose. My take home from today's talk will be, don't be convinced that mediastinoscopy is a dying art, maybe for staging, but for therapeutics, it has its role, and we as surgeons need to pledge to revive it. Thank you.
Thank you. We can get one or two comments, expert comments. EBUS versus VAMLA. Dr. Bhavakos Biswas.
I have not heard what you said, but we had been doing large number earlier. Now the number have come down, but there is still some limited scope. Other models have come, they're easier modality, but putting everything together, there are some cases which have discussed between forums and radiators. There's still scope, and mediastinoscopy is not a dead art. Place of medicine is still there. I have not heard what you said, so I cannot comment on that.
Yes, sir.
Yeah, so just want to comment from Rajiv Gandhi. We published our article on EBUS staging versus pre-op staging EBUS who are negative, and then we compared with the surgical biopsy. So we had 76 cases, and we had upstaging 6 cases, and they were mainly microscopic mats, red tube. So I mean,
it is about 10% that you would.
yeah, that's what it's saying. It's about 8% in our case, 78%. It's quite acceptable. So definitely EBUS is the way ahead. Only thing is on the left side, mediastinoscopy still definitely has got a role. I routinely do it, even if my EBUS says negative, but the nodes are a bit on the larger size. We doubt it because we don't operate on entry disease.
I want to add something. So, in a EBUS negative, whether you want to go with VAMLA or not, that was the question Dr. Dhamija put. I think where EBUS is evolving, I think VAMLA we can consider, and once it is evolved, and this is the future.
I think it all depends on the expertise. We as physicians need to train ourselves well before we say that we are doing a good job. it took us, a couple of months to perform and reach where we are. 10,000 cases down the line, I can talk about EBUS even while sleeping. But for a newcomer, he would take a couple of years to kind of pick up because we are a high volume center. Suppose you do 1 or 2 cases a week, you would not be skilled. You have to understand it is not the machine. Everybody has the same machines, but who uses it makes the difference. Same goes for surgeons. Nobody would do VAM now, but in case we still do not have any data about VAMLA and survival. In case you are clearing the mediastinum in the first step and then operating and taking out the occult metastasis also, VAMLA might score over EBUS also in case you have a long-term data as far as the longevity of the patient is concerned and disease-free survival of the patient is concerned. There's no data on that yet. So things are evolving, but if you ask me compared to VAMLA and VAM, VAMLA, yes. VAM is a big no now. And EBUS, of course, will be the first staging procedure. In case that fails, then depends on the clinicians or the surgeon's judgment whether they want to sample or not, depending upon what particular node they are looking at.
I actually have a question for you, Dr. Dhameja. As someone, I'm sure that you're also designing EBUS training programs. So what would be the cutoff where you say that, okay, now your EBUS is good enough? Like, what is the negative predictive value or the false negative rate that you are aiming to achieve?
I'm a very strict mentor. I would settle for nothing less than 90%. But people say 70 to 80 is good enough, but good enough is not what you actually want to do. It is a mediocre result. So in case you are not give the patient an answer in 90% of the cases, then you've not done a good job. In case a pathologist is trained well, if you're doing the procedure well, the EBUS yield should be always upwards of 88 to 90%.
I think in view of shortage of time, we can discuss afterwards and we'll start with the new session.
I will be starting next session on current evidence and practices. And I will request Dr. George to moderate the MDT case-based scenario. Dr. Pals Khanna will speak, and then Dr. Deepak Abdul will also speak.
Very warm good afternoon to all the delegates. At the outset, I'd like to thank Dr. Arvind, who's been very kind and very supportive. Okay, so without wasting much time, I'd like to share with the distinguished guests here a case that we recently tackled, and we did surgical salvage for a recurrent chest wall leiomyosarcoma. Evidence is hard to come by for a rare tumor, rare subtype in the chest wall. So I took the help of Professor Michael Wouters from Leiden University in Netherlands, who apart from being a surgical oncology, is known for cancer quality metrics. And he, in fact, his team had talked specifically about the surgical outcomes in recurrent chest wall tumors. So in this algorithm, I'd like you to concentrate on the limbs, on the far limbs. Both in the primary and the recurrent setting, if the recurrence is local, there is still a very big argument for offering curative surgery. Straight to my patient. My patient is a 73-year-old gentleman, a diabetic, a hypothyroid, a patient of CA prostate on hormonal treatment, under control. He has had 2 sessions of surgery, which were margin positive for a chest wall tumor, followed by post-operative radiation. These were 7 years apart. Kind of gives us an idea that probably we're looking at a slightly low-grade malignancy here. The last surgery was completed in January 24. In September 23, he was operated, and the radiotherapy was completed in January 24. This is the imaging details of a big tumor, 13.7 centimeters, epicentered in the posterolateral part of the right chest, done for the surgery in September. Surgeon did an excellent job, but probably went shy of doing a full thickness chest wall resection because of which the margins were positive. At this stage, around April, I had a chance to review the patient. The surgical history in 2016 and 23 were reviewed. Radiotherapy had recently been completed. I specifically counseled my patient that because of certain reasons, multifocal, involvement of the fascia, and the chances of an R0 resection are unlikely, and I took the help of my radiotherapy and medical oncology colleagues in the city. And since there was a chance that we would end up with a R1 positivity, I requested their approach for a systemic approach for this patient. That was my first choice, being a surgeon. We did a back check on the previous biopsy report, ran an IHC on it, confirmed it to be a leiomyosarcoma, but grade 1. After 3 cycles of chemotherapy, standard adriamycin and ifosfamide, again, the main point of discussion was, I sat down with my nuclear medicine specialist in the city, Dr. Aditya, is very cooperative, and we did a side-by-side matching of all the size as well as the SUV. This is something as a surgical oncologist is very important, that we don't just let the PET be reviewed by the nuclear medicine consultant. We have to sit down and understand whether our disease is stable, progressing, and then take a more informed decision. Thankfully, the PSA was in the control range, and we kind of explored with the patient that probably again R1 resection is a possibility, so can we go for more chemo? The MDT decided that yes, we can still offer gemdosi, but after 2 cycles, the September PET showed stable disease. There was absolutely no change between April, July, and September. And now my medical oncologist had his hand up that if you can help the patient, very good. Otherwise, we would like to just hold back the systemic treatment for now. The PET, however, showed that there was disease. I'm not sure if it's visible from back there, but the disease is just 2.5 centimeters along the 7th rib, and it's roughly about 3 centimeters around the 10th rib. So pretty scattered disease. There is not one big epicenter, quite unlike what we can see on the PET. Intense uptake. We decided to evaluate the patient and with an informed decision planned surgery. The imaging, we can readily compare the, I'm sorry for the lack of a pointer, please bear with me, but if we compare the left chest wall and the right chest wall, we can make out the disease in its entirety, the loss of the subcutaneous plane, and adherence to the skin. Now this created a peculiar problem for me. How do I plan my margins for a scattered disease? I took the help of my ultrasonologist, Dr. Sarthak. He's an excellent sonologist and radiologist. He was kind enough to sit with me and, okay, please bear with me for the video. And we decided to map the extent of the intramuscular spread or whatever he found unhealthy by using ultrasound. So we could mark out the extent on the soft tissue extent below the previous scar mark, which in fact now extends almost from the midline anteriorly just shy of the nipple. And with this ultrasound marking, we created, ultrasound guidance, we created a surface marking on the chest wall for the soft tissue extent which I had to take out, and based on that, planning my rib resection. We knew through our imaging that the ribs are not involved, they are not eroded. But I had to plan a full thickness resection because the tumor was extending within the lat dorsi as well as the intercostal muscles. So this was the marking which was done preoperatively. We proceeded for surgery, and this is the intra-op surgical specimen. We took the entire ellipse of the skin. We took very wide soft tissue margins, that is the axilla that I'm trying to show right now, reach up till the axillary vessels. We just went under the scapula. So we were very sure that we had to take the 5th rib onwards in our resection. This is the resected specimen, a full thickness resection of the 6 ribs along with an extended soft tissue packet. Our attempt is, the need for this was to secure a margin negative resection. This definitely entailed a very big defect in the chest wall, which was then a challenge to reconstruct. It is also very important as a surgical oncologist to communicate what I have seen in my imaging and intra-op to my pathologist. My pathologist is in the lab. It is my responsibility to orient my specimen. So in my team, we use fabric colors to orient the margins. These fabric colors dry very fast. They stay fast in the 10% formalin, and the pathologist can look them even in the microscopic slides. I use a new technique for me, which I am very grateful for Dr. Dalwam for allowing me to learn it from him. So we use a neorib technique and use steel wires to bridge the gap between the ribs and created a cross link between these wire reconstruction. This was a huge defect. This was almost about 23 centimeters by 15 centimeters. I also was of the mind that I need to provide a soft tissue cover with a muscle since the lat dorsi was not available, and in my mind a 73 diabetic 2 times radiation given, I kept free flap reconstruction as a fallback option. So I decided to move the PMMF partly over it. The challenge for PMMF being that this patient already had a chemo port, so we had to be a little careful while raising it. I used a dual layer mesh. Sorry sir, that was against your advice. Dr. Alam suggested that we use a proline mesh, but I still convinced my patient and we took the extra cost of using a dual layered mesh, vital inside, proline outside. I converted the incision into a TA flap to achieve closure. This is the X-ray immediately post-op. While the patient is intubated, shifted to the ICU. The patient had an uneventful recovery. Around 30 odd days after primary surgery, patient had a fall at home. And by trying to get up on the bed, he fell backwards on his chest. This is the X-ray when he came to me in the emergency after having a fall. So even I was surprised by the amount of integrity to simple steel wires afforded. Going back to Professor Wooter's contention that primary and recurrent chest wall sarcomas have different patterns and we cannot paint all tumors with the same brush. And for a selected few which have a less tendency to metastasize, we can still be aggressive in our approach. I would like to open this case for discussion and inputs from the esteemed faculty as to whether the decision to operate was correct, whether the neoadjuvant approach was correct, and how would you tackle this case in your practice. My personal gratitude to Professor Dalong. This is the case I assisted him in Delhi, and I have the confidence to take up this case here.
Thanks, Paras. That was a lovely presentation of a very difficult case. So as he said, there are many ways to think about it. We've got really good surgeons over here. Srijan is there, Shashank is there, Devyani is there. I want everyone's take, and the decision they would have taken, it's a recurrent tumor. Let me just summarize. With a decreasing disease-free interval, 2017, 2023, 6 months, and now the surgery, and the extent of surgery. And what are the options you would consider? Right? This surgery, is it justified? And your reasons for it. Devyani, first go. You have mic with you?
No, mic.
Yes, I think.
Mic.
Or till you get the mic. Srijan, I'm getting up. Srijan, go.
So congratulations on the excellent management of the case. The one point where I have a pause is the grade 1 leiomyosarcoma. Now, leiomyosarcomas generally tend to be higher grade sarcomas, and which is why if you just say leiomyosarcoma, they are generally chemo responsive. So I think considering that, the neoadjuvant approach was okay, but I would not expect response just because it's grade 1. Because of the decreased recurrence-free interval between the two.
I'm sure we can debate the pathology, but what's your call on this? Would you agree with this decision neoadjuvant surgery or surgery at all?
Only to test the biology.
Only
I would
to
not
test
expect a response.
Excellent. So you would do the chemotherapy, but you would end up operating the patient, and this would be the decision.
Yes.
Yes. Shashank, what's your call?
Congratulations of your innovative technique. I would also like to operate this patient and similar thing, only to test the biology like Stephen said. We'll give the chemo, and the extent wise, I'm not sure that we could not, this is the only way I think.
Okay. So basically both of you agree that you would give chemotherapy for reasons of assessing the biological behavior, and the extent of surgery would have to be radical because there is no other option. Right. Devani, your case?
Agree, completely. Surgery for me, and with a, I don't think I would have managed that.
Yes. So I think Paras, that is a wonderful. So just for the others in the audience, there's a low-grade leiomyosarcoma. I'm really not sure it's a leiomyosarcoma. I think it could be a fibrosarcoma or a fibromatosis or something which is locally recurrent. He's non-metastatic after 8 years. So it's something locally recurrent but not systemic. The DFS is decreasing. It's 7 years, 6 months, and second time post-op RT, it's immediately coming. My only difference where I would say is that I would have kept him observed for a little bit more time just to see how the biological behavior is, because it's from you operated within 3 or 4 months. You shouldn't be shocked
RT was completed in January
Oh, in
20.
Jan, okay.
January 24, sorry.
Okay.
And I reviewed the patient in April. I decided not to operate. I gave him chemo till September 24.
Okay. So you had a sufficient period of
Yeah,
observation.
Absolutely.
The other point is you decided against free flap,
Yeah.
which would have probably given you an option of re-irritating the patient as well, because there is fresh tissue in that area. That's the only other point of view. Because otherwise, all the best to you and to the patient, because I don't think we could have done anything better than this for
Considering
the
that
patient.
twice radiation was given and the second radiation was completed this year in January, do you anticipate that a third?
I've done it before.
I
With the
think,
free flap.
I think, sir, since twice radiation has been given, and what was the time when radiation was given prior to that?
So first surgery was in 2016. Immediately it was a margin positive followed by radiation. Second surgery was
Second radiation.
January 24th it was finished.
So, because in January 24 radiation was given, we couldn't have given more radiation.
Bricky.
No, sir, not possible.
Not possible.
No.
Because normally when we have a local recurrence, the first attempt is external RT, and we usually put fresh tissue and put break into the game. That's how it works.
So, but being a radiation oncologist, I
I'm
would
not
have
sure.
also opted for if he
Fine.
can.
I'm not going to debate that with the radiation oncologist. So I guess you're right. Thank you. Good job.
Thank you so much. I once again like to thank Professor Dalong for, because this innovative technique was something he presented in our AIMS conference.
Wonderful.
And this is what Vinay, my colleague, told me that, and he was kind enough to let me join him for a case. And this is the case that Sir operated in Rajiv Gandhi, which he allowed me to scrub in. And this gave me the confidence to take it up. Thank you so much, Jitin.
Sir, I have one question.
Sure, sir.
The ultrasound guided marking is accurate. One. And rather than using this steel wire, can you use the leavened or leavened on the opposite side for reconstruction? Is it good?
Sir, I would let that other esteemed senior surgeons to answer that. I don't have an experience with using the contralateral rib,
So,
and I decided against using the mesh and bone cement.
I think this is a reason, because you will cause additional morbidity by fracturing another rib. That's one, and then I'll cause flailing. The second thing is, you could either use ultrasound. We usually do a scar ultrasound to check where the nodules are.
Yeah.
Other option is to do an MR, which gives you a more. But as a surgeon, I find it difficult to read an MR, so I guess.
So the
ultrasound is
other
a good
problem
option.
was, I wanted this marking to help me in the OR. And MRI was done. It pointed to a disseminated nature of the tumor in the lat dorsi substance. But my challenge was, how do I identify margin intra-op? And that is why I wanted to do the surface marking.
Wonderful case management. Just one quick question regarding the technique. When you showed your technique about placement of the mesh,
Yeah.
at what level did you place the mesh? It was above the
Above the ribs.
Above the ribs.
Above the
But
ribs.
usually when we do chest wall resection, we try to put it under, and because for two reasons. Number one, it gives a more taut closure and chances of hernia, lung herniation becomes reduced. Number one. Number two, you're also keeping the mesh in the subcutaneous plane when you're putting it above, unless it is covered by the muscle. So usually in our practice, I'm sure others would have done much more cases, but in our practice we usually prefer to keep the mesh underneath and put a tight mesh in that level, and then use the reconstruction and then cover it with the muscle. That way the mesh is way beneath and the chances of mesh getting infected or having problems later on is much less. There's just
Thank you. Point taken.
Yeah.
Thank you, Dr. Pal.
Just to answer that, the idea of putting a mesh above the rib, the new rib is basically, sometimes you need to go back inside for mastectomy, which I'll be presenting tomorrow. I have a case in that. In that case, if the mesh was above the lung, it becomes very difficult to go and basically have a plain tip. And unfortunately, Vicryl mesh is not available in the market, so I'm using Prolene mesh. If you have some infection, it's going to be a hell going below and taking it out. So the idea is basically putting it above the new rib.
Thank you, Dr.
We've been doing that.
Couple of cases.
Viviane, I will just interrupt you.
Sure,
Due to paucity of time, we can discuss over dinner.
Yeah.
Thank you very much. I will request Dr. Deepak to present his topic, and then we will throw it to the House to discuss.
First of all, I thank Dr. Arvind Kohli sir for giving me the opportunity to speak in front of this August thoracic surgeons gathering. And अभिमन्यु बनने का मुझे कोई शौक नहीं है, इसलिए मैंने कोई slide case present नहीं किया. I'll just go through my slides and I'll make you aware that radiotherapy can do wonders also. So, can you play this video? Radiotherapy is basically changing nowadays with the new computer algorithms coming up, new technologies coming up. And in this video, I am showing you can you play it again? I am showing you, can you just, you can visualize this tumor in red, and multi-leaf collimators are moving and conforming to the shape of the tumor. And this is regarding the SBRT which we are doing these days. No offense with surgeons, surgery is the best modality and you should go for surgery first. But if it's inoperable, we can do it with radiation. And since this session is about evidence, early stage non-small cell lung cancer, this is a slide showing variations in international treatment patterns. This is a study done in 6 European Union countries, and CA database from 2010 to 2015 was reviewed, and it was published in European Journal of Cancer in 2024. And what it shows is that observed treatment differences did not reflect differences in survival. So as far as early stage NSCLC goes, we are head-to-head with surgery. So I'll just go through in this slide, show you a case as was being discussed when I came here. That was, I think, last slide of sir, when T3N2 stage was being discussed about. So in October 2023, a patient, 70-year-old male, presented to us with stage 3B CA lung. Histopathological diagnosis of non-small cell CA was made, and the patient, after discussion in tumor board, was planned for chemotherapy, neoadjuvant. Patient couldn't afford immunotherapy. So we planned him for chemotherapy, followed by, after 3 cycles, we planned for to add radiation. The surgery was out at the first instance because the tumor was abutting the heart, as I'll show you in the next slide. In November, patient presented with, just 10 days after the chemo cycle, presented with hemostasis and distress. Case was again discussed in tumor board and planned to add XRT along with chemotherapy at the outset and let chemo go along. This was our prescription for radiation. The patient was planned for 60 gray in 30 fractions with arc approach, volumetric modulated arc therapy. 6 MV energy was used, and patient was to be treated 5 times a week for 6 weeks with constraints to the organs at risk. When we evaluated the plan, first we plan the patient, we give GTV, that is gross tumor volume, clinical tumor volume for microscopic spreads, and then for setup errors at our machines we add PTV, planning target volume. When we evaluated the plan, we had to, you can appreciate this graph, the dose volume histogram, where dose is along the x-axis and volume is along the y-axis. So we were getting 3 red dots because we were, when we evaluated the plan, we were getting reds in esophagus and heart. So we planned again and again to bring it to yellow so that less dose should go to heart. You can see in our system at American Oncology Institute, we have a clinical goal summary and we should abide by the clinical goal summary. We should be having Dmax in esophagus less than 63 like that. And when we got the yellow ones, that is we can go ahead. But for red we can't go. So when we get the yellows, still we were getting more dose to heart and the major airways. And you all know that after radiation, post-radiation, you can get other things also like side effects like stenosis, airway stenosis and other things. And to do away with that, what we decided was, we planned for adaptive radiation. Though our machine can't, the machine which we are working with, we have 2 machines, Clinac and Halcyon. Halcyon 1 model above can do adaptive radiation, But we performed adaptive radiation by planning again and again, because we thought that tumor will shrink within 10 to 15 fractions, and then we can plan again and we can do away, because the mass was large, more than 7 centimeter. So what is adaptive radiotherapy? Just a slide for that. It is modifying treatment plan to improve therapeutic ratio by configuring according to the anatomical and functional status of the tumor during the course of the treatment. And when is adaptive radiation needed? For peripheral tumors, generally we don't do, because there is no benefit in doing for peripheral tumors. But if the tumor is in proximity of organs at risk, what are organs at risk in lung tumors? Mostly large airways, heart, esophagus and chest wall. There is evidence that dose adaptation can be based on tumor pathology also, because squamous cell carcinoma need more dose and other tumors need less dose. This is a study for SBRT done, but we are not doing SBRT here, we are doing IGRT, image guided radiotherapy. Can you appreciate the tumor shrinking and the HU value if you see on the left side and the right side? That was day 19 and this was day 1. Tumor reduced to almost 30%. And we planned that day again, and reducing the by using the modified planning target volume, modifying PTV again started, and the you can see the tumor which was abutting heart give away the planes, and it was the volume was reduced so that we can spare the organs at risk. These days, plan is being optimized daily for image of the day. We have at our center in Hyderabad, we have Halcyon Ethos. Ethos is a machine which has AI in it, artificial intelligence, and it adjusts according to the PTV and treat only that daily. Daily it adapts to the volume. Mostly in lung, we are not doing there. We are doing for prostate and other things. If it's a anatomy like that, or where we need adaptation. But in this case, we utilize this adaptive radiotherapy to our advantage. And this is a picture of day 27. The tumor was reduced to 15 to 20%, and HU value was showing that it's almost gone. These are the various adaptive radiotherapy platforms. From my left to right, we have MRI based Linux, then Ethos in the center, and then we are getting PET based linear accelerators. PET based linear accelerator are in trial stages right now in US, but these two MRI based are available in India, and also Ethos this CBCT based. Can you play this video? One more problem which we encounter when we see a lung tumor is the movement. Can you see? Can you appreciate the movement, how it is moving? It's not like AP and transverse or other things. It's mostly, its movement is called hysteresis. This is a parabolic movement, and there are various studies done by medical physicists on this only, that how much movement is there, and they have seen that superior-inferior it is 1 centimeter, AP it is 7 mm, like this. They have calculated how much volume, how much margin to be given if we are treating a lung tumor, and if there is, especially if it is near the diaphragm.
Dr. Deepak, can you just fast forward?
So what we do for that is this, from left to right, this is a compression belt we apply to the patient to negate the movement, and at our center in Jammu only, to right side you can see that black box. This is RPM device. This is RPM device, real-time position management device, which is configured with the camera in the suite. And what we do is use phased 3 phases of the respiration. We take 10 phases. The maximum cycle we select and fuse that, and then we can reduce the PTV to much. So thanks for patient hearing. This is my team doing work at.
Thank you, Dr. Deepak. Over to George for it.
Thank you very much, Deepak. Lovely presentation. I think we are all heading in the same direction. As long as the patient benefits, regardless of therapy, surgery, in some cases, radiation in some cases. And he highlighted an important point that we are all trying to preserve normal parenchyma, the heart esophagus. I think in surgery talks also, Bilal was talking about segmentectomy where we are preserving lung parenchyma. I think that's the way oncology is heading, that we improve function and the quality of life of the patient also has become an important parameter in addition to survival as well. Excellent presentation. Thank you very much.
Thank you, Josh. Thank you, Deepak. We move to the next talk.
Yeah, I would like to invite Dr. Bhushan for post-chemo lung resection.
Thank you, IACTS and Dr. Arvind Kohli, and greetings from Dr. Bhushan from Apollo Indraprastha Hospital. So we are now heading towards the next generation of era where chemoimmunotherapy will be the dominant thing. So with the introduction of immunotherapy, all those who were operating lung cancer found out that a lung cancer surgeon would be jobless, because everything will be melted by chemo and radiation. But our thought flow will be that overview of lung cancer management. What is the impact of immunotherapy, post-chemo immuno lung resection, how hard it is, and emerging role of immunotherapy, what clinical trial tell us, and what is the future. So this has been the neoadjuvant therapy before the chemoimmunotherapy era. As you can see, it is all color coded. The N2 disease where surgery with adjuvant, and N2 disease with 3A onwards, new adjuvant, and sometimes post-operative radiotherapy. And last is like 3B. We have CTRT, and recently biomarker testing, PDL1, EGFR cross has changed everything, and now we have this kind of management where 1B to 3A, which was 1B was in surgeon's domain, and eventually it went to chemoimmunotherapy domain, and also targeted therapy. So what is the impact of immunotherapy on lung cancer? So routinely we used to give chemotherapy, radiation, and followed by surgery when necessary. But it has made, immunotherapy has made a paradigm shift, offer more targeted and a potential for long-lasting approach. Dramatically changed the treatment landscape, and there has been more interest and among the oncologists and all MDTs to give it as a new adjuvant setting in early stage lung cancer. As we know, cancer is more than a localized disease, where we are heading towards liquid biopsies, and we are seeing more and more reports coming up. We said even in the small tumors, we have tumor DNA and tumor cells, circulating tumor cells in the body. So with immunotherapy, there is tumor shrinkage, improved pathological response, and better immune system activation, and reduced recurrence risk, which may reflect into improved survival, although trials say something. So this is what we want to achieve in after giving chemoimmunotherapy, complete pathological response. We have nivolumab plus chemotherapy, durvalumab, the Asian trial, and the pembrolizumab. We can see clearly from these graphs that complete pathological response is more in the chemoimmunotherapy arms. This is what we want to have, the survivals, the more numbers of people to live longer. So what is the impact on tissues when we give chemoimmunotherapy in neoadjuvant setting or whatever? There is the fibrosis and inflammation in the lung tissue, changes in vascularization, healing potential, immune-related changes, hyperactivations, and or suppression. What are the challenges? There are intra-op surgical challenges and perioperative challenges. Perioperative challenges are increased pulmonary complications, pneumonitis, risk of immune-mediated adverse events, and hematological problems like anemia, bone marrow suppression, and low platelet count, which are in general to chemotherapy also. So these are some of the cases which we have operated last 3 years.
This is like first challenge is the dense to filmy chest adhesions. This was a case where a new adjuvant chemo immuno was given to the patient of stage 3B lung cancer, resectable lung cancer. You can see the bubbles in the pleura and the whole chest lung is adhered to the chest wall. The second is friable lung tissue. You can see, I don't know what you call alveoli you are seeing from the lung surface. And the friable lung tissue, wherever you catch, it starts bleeding. And increased frailty of the tissues. Lymph nodes, if you have good response, the lymph nodes are stuck to the pulmonary vessels. This is a right lower lobectomy picture in interfissural dissection where I have attempted the removal of lymph node and where I failed badly. It was single port robotic. This was the same lady, a 50-year-old lady, recurrent cough, 5 centimeter mass, EBUS positive for 10 and 7, PDL1 19. New adjuvant chemo IO pembrolizumab was given and it was downstage. Whatever the lymph nodes disappeared and she went to URATs to BIRATs and then I had to convert it to open. But I am happy that after doing so much exercise I have pathological complete response and the nodes are negative. So this is like the same case where I am attempting the removal of the lymph nodes. It is all messy operative field. It is oozing. Then after struggling for half an hour to 1 hour, I thought it is better to convert rather than keep on digging inside and have an accident, which is an unplanned manner. So another 3B patient, 70-year-old gentleman, chronic smoker, PET CT 6 centimeter mass, EBUS 4R positive, CT biopsy, EGFR all negative, PDL1 9%. Our MDT decided to give nivolumab plus chemotherapy, and this is what we have at the hilum. There was a nugget stuck at the truncus, and oops, I was doing unipotent wax and started bleeding. So everything was stuck. With one hand on the sponge holder, I tried to dissect vessels. I ligated all the vessels by wax. And there was no other way. I thought over, asked a few people around to mass staple and get out. So I had to mass staple it. It is almost 1 year down the lane. The patient is doing fine. So everything is stapled together. Just I have to see whether the lower lobe pulmonary artery is pulsating or not during the surgery. So this was the X-ray picture, and I was again happy. The histopathology was complete tumor response, no viable tumor, nodes negative. Follow-up period is still 1 year, recurrence-free period. There was some impact in getting him to surgery because he has low platelet count of 55 kb. We had lost a lot of time in optimizing it. 8 weeks, I had operated at 8 weeks post last the dose. This was another patient of nivolumab chemoimmunotherapy. But you can see the nodes, how they are there. This is again a URAT's case, right lower lobectomy. You can see the nodes are not stuck. They are coming out easily. After the surgery, I got the histopath. It was partial response. This is again a salvage setting. The tumor initially regressed, then started increasing. And with URATs I started. It is again right lower lobectomy. The bronchus and the lower lobe pulmonary artery I could not get it separate. I decided to put a stapler through another hole in the fifth intercostal space and mass staple it. Now almost 8 months down the line, patient is disease free. This is another salvage setting where a squamous cell carcinoma patient, huge mass with EBUS positive, even pembrolizumab based chemoimmunotherapy. A lot of times the adhesions are so dense you don't know what you are ligating and what you are clipping out. So most of the times you have to suture ligate the vessels intraoperatively and hold. This patient had azygous injury. I had to open in the middle of the night and then redo everything. So this is another case of after pembrolizumab, the anatomy was distorted. And I was attempting the interlobar PA to get it loop around, but see, so dense adhesions and it was an oops movement. And I had to hold this artery with my hand for almost 1 hour till I get the things on track. This patient is doing fine. She had one nodal recurrence which was radiated later on. So this is the another challenge, the messy operative fields and all everywhere, blood everywhere. So what evidences we have? So many trials are going on. Nivolumab, atezolizumab, nivolumab, durvalumab, penrolizumab, and I don't know many other drugs will be on the pipeline. So this is what we are achieving. See, only IO, the greens you can see surgery is that much. So surgery is not affected by chemo, immuno or anything. The main is the yellow graphs. We are achieving the pathological CR, but we are not able to have that much difference of around whether this patch CR is getting converted into the survival advantage. This again, the chemo radiation with IO with chemo radiation. You can see the graphs. Graphs still surgical resections are still 80%. What neoadjuvant trials tell us? They tell us the likelihood whether the patient is going to respond or not, clarify the mechanisms, and which unnecessary operations can be prevented. Obviously, these procedures are much challenging. We can't predict on the OR table. It is like a live battleground when you operate such neoadjuvant cases, and when they are postponed, and you are doing these cases at a later date. So what are the impact on surgical outcomes? There are some missed opportunities, delays, increased operative difficulty. But you can see there are similar or greater rates of surgery. So Checkmate 816, Keynote 671, Asian trial, no delay in surgery due to receipt of chemo IO. So chemo IO is the way future. The impact on surgical, the difficulty, they are challenging than, it is more challenging than standard lobectomy. MIS is not affected or impacted by IO. Conversion to open less frequent, but I found almost 10 to 20% opening my cases. Oncologic and post-op recoveries R0 resection. Whatever you do, everything has to be R0 resection, otherwise the job is not done. So 90-day mortality, you can see little bit of this high, 4.4% and 1.6% in chemo alone. The impact on operative conduct by various colleagues, surgeons have just 40% operations to be more complex than usual, and the 19% lasted more than 5 hours. I have operated now 7-8 hours also sometimes. It's like, this is the graph where you can see completed neoadjuvant therapy, underwent surgery, minimal invasive approach, 30, you can see well, and pathologic response. You can see from the control. There is a complete pathological response. So recap. So there is fibrosis, adhesions, sclerotic lymph nodes, risk of bleeding, longer operative time, the lymph nodes may not come up. It is very difficult to predict on the scans whether it is a living tumor or a dead tumor. These are the final recap. So future is no surgery or more surgery, but salvage lung resections, if we are not the first, we might be the last, because there might be sometimes these chemoimmunos might fail. The biology will be different. These are some of the papers I got. Salvage lung resection is feasible and safe. So another future is like Northwestern University, Dr. Ankit Bharat is doing double lung transplantation for bilateral lung cancer, maybe in near future. So multimodality options are rapidly increasing. Neoadjuvant potentially improve the benefit of curative surgery. Lung resection can be challenging at times. Minimal invasive methods can be adopted with comparable outcomes. Precision surgery, the era of precision surgery. The emphasis is on the collaborative care, MDT management. So it doesn't seem so. There will be more work to do. So more for stage 3 will come to surgeon's domain, and even maybe in future, stage 4s may also come into surgeon's domain. Thank you.
Excellent talk, Dr. Bhushan. I think this is not the first time in oncology where surgeons have been challenged by neoadjuvant therapy and the increased difficulty of operating, which lasts for few years, but then surgeons always find a way to cope up with that. So will be the same with chemo, immuno and lung. What are your strategies? You said having a lower threshold to open based on your experience is in the safety of the patient. Are there any other, we saw that you took some proximal control, distal control. Would you say that's necessary for upper lobe resections?
Sometimes. Most of these nowadays we get chemoimmunized N2 disease cases. So with good response, these nodes will be plastered to the pulmonary arteries. So you should be prepared in a mindset of doing double sleeve resections, and even also sleeve bronchoplasties with this. That armamentarium has to be there. But whenever I think of converting non-progression, and think about OR times also, because due to chemoimmunotherapy, they might be having some pneumonitis or some reduced lung function. If you increase the duration of surgery, obviously you will be able to do the surgery, but later on I had a problem. The patient went into pneumonia, and after 1 month he died of unknown cause. I gave methylprednisolone, whatever was there on the earth I could give. I tried to salvage but couldn't. So that should not be happening. So 1 hour is a fair enough where you can't progress. You find it, don't make any accidents. Would have seen those accidents, the pulmonary artery getting. You see with your caliber and judgment, this is the case where I have no help or I can't manage later on, whatever. Just open it, take the control, your thumb is there, you can trace always and do the dissection. Sir.
There is always scope for surgeons. I fully agree, surgeons will not be jobless. Whatever newer modalities come, surgeons will have more and more job. The only thing you have to innovate. What to do at this stage? There are some options. It may be conversion, mass ligation, or stapler. There are a lot of options, but you have to put it judicially. Only one point I talk to my juniors while about difficult cases. As soon as complexity goes, keep your head cooler. Don't shout on people. It is your turn to solve it. Bhushan has worked with me, he knows. Problematic is you have to take. And when things go more and suddenly dissecting pulmonary artery comes in your hand. Whatever happens, you believe that everything is manageable surgically. You should have weapons and your armamentarium. You should have your brain cool friendship. Thank you.
I think we started the day with Dr. Sri Krishna sir saying you have to be a warrior. I think that's the message in chemo.
Thank you.
Thank you so much, Dr. Bhushan.
Thank you.
I think the next session, we move on to the next session. The speaker for the next talk, I think is not available. We thank you, the organizers, for giving us the opportunity to chair this session. Thank you.
Now let's move on to the next session on rats and robotics. I would like to call upon stage the next chairpersons, Dr. L.M. Darlong, Dr. Harshvardhan Puri, Dr. Manjunath Bale, Dr. Bhushan Thombre. Please come on stage. The next speaker is Dr. Ajay Narsimha, who will speak on the topic uniportal robotic surgery for lung cancer. Over to you, sir.
Good afternoon to all. Without wasting much time, I'd like to go on to my topic. I thank Dr. Arvind and IACTS for giving me an opportunity. It's not moving. It's not. Okay. So the positioning is the same, like for all minimally invasive surgery, and the incision will be in the 7th intercostal space. I generally use 3 ports, 3 8mm trocars and 1 12mm trocars for the stapling. This is what Dr. Diego uses, a modified version of the Da Vinci trocars, which we don't have access to. And the position, I keep 3 rolls, one below the shoulder and one in front and one in the back, and I tape the patient and break the table. So with this, this is how we position the robo on a mannequin. So you make sure that the long arm is parallel to the longitudinal axis of the patient. And then when you are doing the surgery on the left side, make sure one arm is cancelled. The arm closest to the robo is cancelled. You can see here the arm closest to the robo is cancelled. And I prefer to stow it away sterile, so that in case you require to convert it into a multi-port, I think it will be better and easier for you. So the camera goes in the posterior most arm. So, and then you dock the remaining arms. You don't do targeting, so you can skip the targeting part. And then under vision, you dock the camera. So once you dock the camera, you dock the remaining 2 arms. First, the trocars. The advantage of uniportal VATS is everything is through the same thing, so any conversion is easier. But the disadvantage is all the arms should always be parallel to each other. You can see, without vision, you should never go. See, the right arm is being pushed inside, and at the same time, under vision, make sure you are able to push the other arm also. So you can see the left arm coming here. This is just in a mannequin demo. So I've just made sure both the arms are visible before I actually take control and adjust the hand controls. And you can see the 4 markings FLEX. Make sure the robotic arms are centered to the markings FLEX. And this is how it looks inside. So the camera in the posterior part of the incision, the arms parallel to each other, and this is how they work in the chest. Parallel to each other. So these arms don't cross at all. And this is one important thing that we have to do in uniportal racks, because your arm controls have to be manually reconfigured. Here we are doing a left-sided procedure I was showing you in the demo. So we have cancelled out arm 4, and you have to manually switch so that you can see the arm 4 is away, arm 3 is the camera, 2 is the right arm, and 1 is the left arm. So remembering that, you can make 2 as your right arm, but the moment you make 2 as your right arm, it will give you an alarm because 3 things will be assigned to the right side. So you have to change it and accordingly make sure you are doing that. So what are the common challenges that we face in uniportal racks, and especially in a country like India, as Bhushan was rightly pointing out, a lot of additions are there. So you can see here, this is the additions at the entry point, and this is the additions of the aortic arch on the left side. This was a case following chemotherapy. I have not operated post-immunotherapy with a robot, so I don't have any experience with regard to that. But we do get post thing. So, and these are the challenges that we face during insertion of the stapler. You can see here, I've showed you a clip what happens inside the chest and what happens outside the chest. This is a slightly longer video, so once we have exchanged the trocar, the 8mm trocar for the 12mm one, the assistant at the thing, and he adjusts the arm and he inserts the 12mm trocar corresponding to our right hand. We choose the appropriate stapler, and under vision he comes in. The disadvantage of uniportal VATS is all the arms have to be parallel to each other. So the stapling, the organ which has to be stapled or the structure which has to be stapled is pretty close to the incision. So you might have to adjust the stapler a bit. So you can see on the right side the stapler is being pushed in. There's a delay of 1 second, so pardon me for that. So you can see the stapler being pushed in, but once he gives the control, we realize we still don't have the enough articulation angle here. So what we do, we ask the assistant to pull out the trocar a bit. So you can see that stapler coming out here. On the right side also you can see the stapler coming out. Once we do that, we now have enough space. The principle is the same. Never staple if you are not able to see the tip of the stapler. So once you see the tip of the stapler, you can see it here, then you remove the loop and then you can go ahead with stapling your thing. And with malignancy, we tend to do more and more segmentectomies whenever possible for early stage malignancies. In single port robotic also, segmentectomy is possible with the use of ICG. After we isolate the segment by cutting off the vascular supply, we ask our anesthetist to give ICG. You can see the lung lighting up in the firefly mode, and we mark the parenchymal line of resection with our energy device. This was a lingulectomy that we did. It was published on CGSNet. So once we are done, once we are marking our stapler line, we decide to go ahead and you can see always in all the videos, the two arms have to be parallel to each other. There is no question of crossing your arms. Once you have marked it, you can see the marking here. You can take the appropriate staplers and complete your line of firing. And lymph node dissection. Again, you can see the arms are parallel to each other. This was a right middle lobectomy. This guy was an interesting guy because he had 2 primary cancers before. This was the 3rd time primary cancer, so he was a syndromic person. He already had lymphoma and some head and neck cancer, and he had come for a middle lobe non-small cell lung cancer. So this guy was post chemo and RT again. RT to the neck, not to the chest. So the same principles are the right and left arms have to be parallel to each other. At times the assistant uses a suction or some instrument to retract. You can see the assistant pushing down the azygos with his retracting the azygos with his suction, and then we are able to get the lymph nodal packet. These are all small representative videos. I'm not showing you the complete videos for want of time because I'm sure everybody will be doing all this. So just for the sake of discussion, you can see you can do an ambidextrous dissection. It's not that we can't do an ambidextrous dissection when you're doing a single port robotic surgery. We'll see 2 station 7 approaches. One is following a right lower lobectomy. You can see the right lower lobe hilar stump is here. We ask the assistant to retract like that. So once he is ready, he comes in with the suction. So he comes in with the suction, sucks out the blood, and make sure he shows it properly. So once he shows it, start showing, you can see the subcarinal space. There will be some clashes initially. I think your assistant should be a really good and skilled person, and you should talk it out before you actually do these steps. Once the initial challenge is done, then you will be able to do all these cases. You can see the subcarinal space being exposed. So that's how it is for following a right lower lobectomy. Here it is slightly easier because we have enough space, the lobe is out, so you have space for the instruments to move around. You can see the node being exposed. I'll be stopping there. This is following a right middle lobectomy. The upper lobe is still here, the lower lobe is still there. So you have to navigate slightly in depth and open out the posterior mediastinal pleura. Because lymph node dissection plays a very important role in the management of lung cancer. The key point I keep repeating in every slide is the instruments should be parallel to each other. I think once you overcome this mental block that the instruments should be parallel to each other, I think then uniportal RATS is doable for pretty much everyone. So with that, I'd like to conclude my talk. So we have done close to 37 cases now, and I think we are getting there. So if I would be happy to take any questions. I think I'm ahead of time. Thank you.
If you have to tell two main problems you're facing, like in a sense, drawbacks you can say from URATs.
See, the drawbacks is the initial part of our journey of URATs, there was a lot of clashing between the trocars. So, and the entry is always difficult when you go with URATs, because if there are additions at the entry point, then you might have to dissect a bit with VATs and then go ahead with URATs. And once you are able to overcome the clashing, apart from the clashing, I don't foresee any major problems with the thing. Of course, conversions are definitely easier. The level of thoracotomy is slightly lower, so you have to be prepared for a lower thoracotomy when you are going to convert. But the conversion is easier because you can directly pull out all the trocars with as you keep pressure. So the conversion becomes easier and quicker. But level of thoracotomy is lower, so you should be prepared for a lower thoracotomy when you are operating with open surgery. But any reasonable experienced thoracic surgeon will be able to tackle those things. The only thing is the clashing of the trocars, and your assistant should be a really good person to help you with the challenges that you face. Because as sir was saying, we should not take it out on anybody else. We'll be frustrated at that point of time.
Very nice presentation. How any accidents you had?
Touch wood, as so far we have not had any accidents. We have converted into a biportal robotic, but we have not had any.
Yeah, so I generally convert it in 15 intercostal space. So this is a small portal incision where you need to get access, because I had a conversion. The truncus had got injured by just negotiating the stapler, and a node was there. And forcefully I just pushed it and it got...
Post immuno I am more comfortable doing by VATs, because I think I feel I have more control with VATs than robo.
Yes, because robot you are somewhere else and it takes time
So,
to go to. Obviously the patient was safe, but it was like a oops movement and it was a running helter-skelter.
Correct.
The next talk is from my mentor, Dr. Rajendra Prasad. The talk is on VATs in mediastinal tumor.
They are setting up the laptop. I would like to say that now it's one of the biggest pleasure a teacher can have is to see his own students sitting as chairpersons in the dais. It just speaks about the efficiency level they have achieved, and I really feel blessed to have had students like that. Manjunath is there, even after Darlong was at some point in time my postgraduate. So I'm very happy to see both of them sitting there as chairpersons. And so the task given to me is to speak about VATs in mediastinal tumors, and I'll try to keep it short. So they are kind of rare tumors in the thorax, and there's a wide range of diagnosis. So sometimes they are found incidentally, particularly the posterior mediastinal neurogenic tumors, or they may have some symptoms arising from either compression or involvement of adjacent structures. Surgical resection alone or as a part of multimodality treatment is the way to go. But it is a challenging situation because there are multiple vital structures in a limited non-expanded space. These are the traditional approaches to the mediastinal lesions, and with increasing experience in VATs, people have resorted to using this approach too for mediastinal tumors. So this is the atomic classification of various compartments of the mediastinum: prevascular, visceral, and paravertebral. And these are the common lesions that you will find in purple in the anterior mediastinum: thymus, germ cell tumors, and lymphomas being very common in the anterior mediastinum. And these are the middle mediastinum where we tend to see cysts, etc., paragangliomas. And in posterior mediastinum, we mostly will have neurogenic tumors. Slightly more than half of all mediastinal masses are located in anterior compartment, and the rest are distributed equally between the middle and the posterior. I will come to some illustrative cases where we have used the VATS approach. in dealing with the mediastinal tumor. So this one is a ectopic ACTH secreting tumor in the thymus, and this one is an ectopic parathyroid adenoma again in the thymic region, which was taken out using a robotic approach. Posterior mediastinum usually, as I mentioned, has the neurogenic tumors, and the stars represent the areas where you will have these posterior mediastinal tumors. They have the challenges that you will see in dealing with these depends upon their location. If they are somewhere in the middle, it's okay, easy. But if they are in the extreme, upper extreme or the lower extreme, then it's a very challenging situation to deal with. Because of space constraints, they are solid lesions, difficult to manipulate, and you have critical structures. And some of these tumors can be very vascular, as you will see in the coming slide. So these are some illustrative cases. Say 35 years old female who had a dry cough for a year, and on clinical evaluation she was found to have an MNG, and then subsequent evaluation also revealed a lesion in the mediastinum. FNAC was done from the thyroid region, which was Bethesda 2. And if you now see this kind of corresponds to the middle mediastinum, not to the anterior mediastinum, where the thyroid will usually descend in that region. This is how we approached it. This patient was with my other colleague, and she was very keen that I should take out this thoracic part through VATS, and then she wanted to do a endoscopic approach to the neck part of the thyroid. So this is how we position the patient, more like what we do in thymus, and this subsequently was published also in BMJ. And this is a video. As we entered, you can see this large tumor, and that the SVC, and you can see the phrenic coursing over it. Unlike thymomas and all, this was a very soft lesion, and it was in a very critical location. You can see the superior pulmonary vein here, and so we decided, okay, we'll try and see if we can get away with it. So slowly and slowly we dissected along the pleura and went down, and then it's very close to all the critical vascular structures. So it's important to clear the surroundings so that you have a clear view, and then you see this big vessel which is entering there, and we took this vessel. And my personal preference in situations where you are very close to either vascular or airway structures is to use a ligature rather than harmonic. Sometimes the vibrating limb of harmonic can itself produce a little bit of an injury. So that way I find ligature in very critical location where you are very, very close to the trachea. Here we are running right next to the trachea, and slowly, once we got the critical structures out, you can see there slowly. And fortunately, this lesion did not have any continuity with the neck part of the thyroid, as you will subsequently see. And slowly we were able to detach it. And I would just like to show you the end part of it, how it looked at the end. And this is the last bit being taken off. And it did not have any continuity with the intrathyroid thing. So this is how it all came off. Then we put it in a bag and took it out. And here you can see the trachea is all along there, and you can see the azygos crossing over. Now these are some of the posterior mediastinal inferior sulci. That was the superior sulcus tumor, and these are case series of some neurogenic tumors in the inferior sulcus. One of them was a functional lesion, paraganglionoma, and patient had all the, and you can see these, they are deep in inferior sulcus, and this is the another one. And sometimes it's very challenging to decide which way to go, whether you want to go through abdomen, through the chest, but we decided to go through the chest, semi-prone position, left-sided and the right-sided, both semi-prone positions. And you can see this. The first one, it was a very, very vascular lesion. One of the problems with these posterior mediastinal lesions is when you are working close to the bone vertebra, there is no purchase that you have. So they can bleed a lot there, and there is nothing that you can hold on to and cauterize or something. So in this particular patient, we had requested our JSIV colleagues to give us the organ, and it did help us. and slowly and slowly, and this one is on the other side. That also you can see the difference in both of them. This one is not so vascular, this is on the left side. On the right side, you have to get the diaphragm, you have to have one instrument just to keep the diaphragm out of your way, which is not so in this particular one, which was on the left side. And on the right side, you also have to be careful about the thoracic duct coming in that region, and that you will see towards the later part. So you can see the difference, how different they are. So the varying configuration, the varying heterogeneity or the vascularity, it can all. So that was the thoracic duct we thought we needed to ligate. There was one more patient in whom, after the dissection was done, then we washed it and we gave something through the rice tube, and then there was some chyle coming, and then subsequently that too was ligated. So you can see the difference in both, and that is very right next to the vertebra where we were using the argan. And wherever you have some tissue, there you use a harmonic or something. But very close to the bone, this is the argan plasma being used. And on the right side, on this side of the screen, that side you can see it is much cleaner. And here is the, we've just taken out the vessel, the nerves through which it was coming. And this one was then, both of them were then finally divided and put in a bag. So here you can see finally this one too being taken off. And these are the remaining attachment, and then it was taken off. And here you can see the cleaned off area, and put some gel there, so it is or something. But make sure if you are doing this on the right side, be mindful of the thoracic duct. Nowadays you can use ICG and all with the availability of ICG. Maybe robot can be a little bit of help in these areas. Now this is the esophageal leiomyoma. I'm not going to be talking about thymus because it's a separate chapter in itself. So the other tumors that we have encountered are, this one was also published in Needle of Cardiothoracic Surgery. And this is the case of leiomyoma, a person who was detected to have this on a routine chest X-ray. He wanted to go abroad for a job, and then subsequent CT, you see almost circumferentially this esophagus has been kind of encased by this, is kind of arising from the esophageal wall, and kind of it's almost circumferential. We were a little skeptical whether we'll be able to do it through VATS, but we tried it again, semi-prone approach, and this is what it looks like. So that's the tumor, the aorta, the vagus was coursing over, that's the diaphragm. And I think this semi-prone approach is very helpful for these kind of lesions. And here we start, and the problem with these lesions is that they can flip-flop, and that's the aorta you are seeing there. You have to find the junction of the tumor with the normal esophagus, and we also try to see that the vagus is kind of pushed aside, and just to stabilize it, we took a stitch and kind of through the outside we stabilized it, and then we were able to see the esophageal junction here where it kind of joins the esophagus, and then just like we do a myotomy, in a similar way this lesion was approached. And then we kind of were able to, you can see that's the mucosa part, and this is the muscle part. And this muscle, the mucosal tube, you will see developing along as the tumor came off. So slowly and slowly we were able to clear it off. You can see this mucosal tube developing, and at the end we were able to totally detach it. Then we did a endoscopy, looked all right, but because it was very large tumor, we also decided to do a methylene blue test where we saw some dye, leaking. Then we put a stitch there and then closed the muscle layer over it. And here was the endoscopy initially we did, and that didn't show anything. But then once we put the dye, you see that pinpoint hole there, and so we closed it up, sutured it. That was just a pinpoint thing, and then put the muscle over it. And that patient did well and kind of went home. So to conclude, ladies and gentlemen, VATS is a reasonable option for mediastinal tumor if you have some experience with VATS. Patient selection is all important. I think it's important everywhere. Advantages are, of course, reduced pain, quick recovery, early return to work, and you can probably get equivalent outcomes in terms of oncological outcomes in properly selected patients. Thank you very much for your kind attention.
Thank you, sir. It was an excellent talk. Sir, have you seen any posterior mediastinal bronchogenic cyst?
I haven't seen, but most of the time when we have seen some of the mediastinal cysts, but they are not so far down and so far deep. Usually they are more close to the airway structures. The sulci are the unlikely sites.
We'll call next speaker since we are running short of time. Dr. Shilpa will be talking on pulmonary hydrated disease.
Good evening, ladies and gentlemen, and I'm here to present an account on pulmonary hydatid disease and the principles and practice of VATS in these kind of patients. So my talk is loosely based on my own thesis, which I did in 2017 and was published in 2018. We did single stage management of multi-site, multiple hydatid disease. Coming to the epidemiology of hydatid disease as such, you can see that the graph shows that it is present everywhere across all parts of the world. When you look at a deeper aspect, so there are a lot of areas which are endemic. However, there are some areas which are hyper-endemic when you see it in the graph. And these are the areas where cattle grazing is common, or these are the farming areas of the agricultural background areas. And hence we know that the dogs are nothing but the definitive host, and humans are nothing but the accidental host, or they are nothing but the dead end. The endocyst, which contains the protosporolysis, are actually the infected form. We all know that whenever lung cysts are formed, they grow faster, at least 1 to 4 centimeters per year. However, liver is the most common organ which is affected by by echinococcus, followed by lungs, and then rest of the organs. Pulmonary echinococcus, if you ever come across, then the right lung is more commonly involved, especially the lower lobes. The indications for surgery are really very easy and upfront. Large cysts, if they are superficial and they are likely to rupture, or if they are infected cysts, or if the cysts are located in vital anatomical locations, then this is exerting substantial mass effects. However, the gist of the operation is nothing but to eradicate the parasite, then to prevent intraoperative rupture and subsequent dissemination. You have to eliminate the residual cavity as well, while also preserving the lung tissue. Contraindications, really not as such. These are just basic contraindications, for example, coagulopathy, or failure to achieve fitness to general anesthesia. Coming to pharmacotherapy, it can be used only as an adjunct therapy, and this is predominantly used only for smaller cysts or multiple cysts, or cysts which are really young with thin walls or very high metabolic activity, or the cysts without any daughter cysts inside. What do we use? We know this benzimidazole compounds, and the dose is very standard, 7 to 15 milligram per kg body weight. At least you have to give 4 days prior to the surgery. but it should hardly be continued for at least 1 to 6 months post-operatively. Continuous therapy is preferred over cyclical therapy. Yes, we do have some contraindications to this adjunct pharmacotherapy, and they are the cysts which are impending to rupture, or if they are inactive or calcified cysts, if there is an underlying bone marrow depression, or the patient is pregnant. Coming to conventional surgical techniques, there are really endless lists, but we have to talk about it. The first is nothing but enucleation, which is not the basis of the surgery. That is, you remove the cyst with an intact germinal membrane. When you do the same procedure with positive pressure ventilation and a low tidal volume with high peak, it's called as a Barrett's technique. Cystopericystectomy is removing the cyst intact along with the pericyst. And cystostomy with capitotonage is nothing but first aspirating or decompressing the cyst, removing the germinal membrane, and then obliterating the cavity. This is most commonly done for very large cysts. Posada's technique is nothing but the same, but you have to check with the bronchial openings, and if they're positive, you have to take care of it. Figura technique is somewhat a minimal access technique, where you just do open aspiration and then you infiltrate some scolicidal agents, and then again a reaspiration. Yes, anatomical resections, we have to resort to it as a last option. And when we do Barrett's technique, this is how the picture is, and what we remove is nothing but the pericyst membrane, which is the outermost layer, the inflammatory host reaction. Then the inner one is a parasite layer, or parasite origin laminated layer, and then comes a germinal layer which produces everything. Coming to rats and parasitic diseases. So yes, there are a few studies which have shown, or where people have used rats in these kind of these settings. I would just quote one paper, and this was where they studied unipotal or UVATs with an open thoracotomy for pulmonary hydatid disease. It was a propensity matched analysis where the first cohort was nothing but the thoracotomy comprising of 16 patients, and the second one was the UVATs comprising of 23 patients. The operation time was found to be higher, obviously, in the thoracotomy group. Then the level of post-operative pain and all of those, they were found much higher in the thoracotomy group. But however, the hospital discharge and the early recovery and all of that was found in the second group, which is nothing but the VATS group. However, there was no significant difference in the ICU stay. There was no significant difference in the recurrence, or neither with the 30-day mortality, and that's what we want. Whichever is the approach, but the outcome should remain safe and feasible for all the surgeons as well as to the patient. But it did prove that unipotal VATs can be safely employed in these subset of patients. I would like to study just a few of the interesting cases which I've come across. So this was a patient he was a 19-year-old gentleman, very frail. He came with a very huge hydatid, occupying almost the entire left hemithorax. It was 20 centimeters. He was harboring it since 18 months. And he was already on albendazole therapy. The bronchoscopy was negative. He just had a very peculiar, complaint of coughing, just liquidy fluid. So we did a workup of this patient, and then we took up for VATS. We did a capitotonage and a pericystectomy. However, this patient was already consented that we have a parenchyma preserving intent, and there is a possibility of a recurrence, and that will be dealt accordingly in whichever way and when it presents. Hence, it did present to us on 4th of month. At that time, we again took the patient. This time we did a mini thoracotomy with a pericystectomy of the residual the recurrent hydatid, and a thorough debridement and somewhat of a decortication of the residual space. So these are the pictures of at the end of the first surgery, where just a UVATS was done. As you can see, the X-ray was really good, not only on the day of the surgery, but also at the time of discharge. And if you can appreciate the pericyst, really, it was an extremely thick-walled pericyst. I have a video to show. It is a 9-minute video, and I'll try to show you the main points. So it was, to begin with, I would definitely say that it was a never-ending cyst. a 20 centimeter cyst. I would have never imagined doing it by VATS. So much was the cyst under high pressure that by the time I said start recording, we already had aspirated the fluid, so that has not even come on the video. So we first decompressed the fluid or the cyst, and while doing that, we ensured that the surrounding parenchyma was covered with a gauze soaked with scolicidal agent. I prefer using hypertonic saline. Then the adagiolysis. There was the next step, which was a tedious process. And it took really a long time, and the cyst was really extremely adhered to the chest wall, diaphragm, and medially to the heart. This is a 4x video, and hence some of you can find it very jerky. So I'm going to take it forward a bit. Yes. So we're still going on with the adagiolysis. So yeah, at some point, then once we mobilized the entire cyst, we found from the site where we had already aspirated the cyst, where we entered inside, we took as much of the daughter's scoliosis as possible, and we aspirated the whole fluid. Then from there, we took the leverage of that wall, and we did the cystectomy or a pericystectomy of the the large high adult. So this is now the a lot of it the pericyst we are holding, and we're taking it out as much as possible. Yeah. So once we were able to remove as much of the pericyst, the wall pericyst, the residual cavity was closed using a purse string, putting a purse string suture. Yeah. And then the rest of the pleural cavity was then washed with a hypertonic saline. This again was a tedious job. So I think that is the gist of it. So as I mentioned, that this case presented again at the end of 4 months, and as you can see, at that time we did a mini thoracotomy from a space below the previous, the VATS space. There was no viable or active daughter's scoliosis we found. There was a residual or a recurrent cyst with some mucky fluid. So we did a decortication with a residual pericystectomy. However, we were able to get away with any kind of a lung resection. And these are the follow-up chest x-rays. So this patient was also discharged on a prolonged chest drain with the same intent that we want to take the drain out once all the residual space is fully filled. And we took the drain out at the after 2 months. So this is the picture at the end of after 1 month of drain removal. There is a small loculated space. However, that space has now filled up, and the patient is already in his 3rd month follow-up. This was another interesting, not interesting actually, this was another presentation. There was a lady who had a right hepatic hydatid cyst in the segment 6, but she already also had a ruptured pulmonary hydatid cyst, and which led to symptomatic infected effusion on the right side of the chest. She used to have frequent pains as well as frequent episodes of LRT, and that made her to come to us. She underwent a simultaneous VATS and hepatic cyst excision. Here in this case, what we found was the hepatic cyst was intact, and our neurosurgeon very well removed it in toto. And this was a very easy and upfront UVATS management of the ruptured hydatid cyst. And these were the chest x-rays on first day and on the day of the discharge. This is the last case which I would like to say, and this is a peculiar case because, again, the history was very similar. Again, a solitary large hepatic cyst, which was nothing but an intact or an unruptured hepatic cyst, but a ruptured right pulmonary highlighted. We took with the same intent, the same sitting surgery, and we added an easy peasy. It was an easy peasy UVATS, debridement and washout of the right chest. And the liver surgeon did his hepatic, highlighted cystic lesion with a pericystectomy. However, this patient landed up with a, so as you can see the X-ray above, it shows the lung really struggling hard to expand because then we, with due course of time, we learned that he had developed a stress-induced cardiomyopathy. I think we really have seen a lot of, fair number of highlighted cyst surgery patients. I have not encountered this kind of complication, at least in my practice. I'm happy to know what the audience feels about it. Yes, so coming to an end, I think that yes, so every surgery and every patient and innovative techniques, they have a flip side to it. I would say this is not a flip side, but a take-home message. If you want to do a same-sitting surgery, especially in pulmonary highlighted, and that too with the VADS, you should need a well-equipped setup with a specialist care, that is a thoracic surgeon, a dedicated HPB surgeon with a proficient anesthetist, and a good, very good, an ICU backup. The disease has to be right-sided. You have to be prepared to deal with unusual complications. Squalicidal agents use is a must. Adequately informed consent is really a priority now. And you have to mention also about the anaphylaxis. Parenchyma preserving surgeries, yes, it is not just the ideal, but it should be preferred. I would end up by saying that minimally invasive approach does offer much more advantages as compared to pulmonary, irrespective of the size, location, number of the cysts, and number of organs. Thank you.
Thank you, Dr. Shilpan. Those were a nice collection of cases.
Thank you.
Any questions? One or two questions.
It's a very common problem in this part of the country, in Jammu, Srinagar, this sub-Himalayan range.
Yes.
We have done so many cases of lung, but what I slightly differ that we never required doing pericystectomy in lung highlights. It may be required in liver, in spleen, in other issues, but that is something which maybe we were lucky we never required it. And I think doing a pericystectomy in lungs would create a lot of mess, lot of openings and air leaks. And
So, you're right actually. But like I said, this was also my thesis topic. And really, after JNK, probably I would say Bengal would come as a second state where we've encountered a lot of these kind of cases. And the step which I have not shown in the video, but it wasn't there, but we have already checked, and that is for the bronchial leaks, the pulmonary, the small bronchial leaks. But we did not, thankfully, we did not find it, and so we need not, close it. But yes, I agree with you. Pericystectomy, if we do, especially in the lung, it will lead to a lot of leaks. But I'll say, in this case, the cyst wall was so thick, I wasn't expecting the the leaks to come up or to be visualized. So I
because even when we do not do pericystectomy, we remove the cyst as such, even intact cyst. Even then there are few
bronchial openings.
Yes.
Definitely.
We have
I've seen a number of
few
patients.
stitches, proline or whatever. So that is required. But if we do pericystectomy, that's what I feel.
I don't think pericystectomy is required. The only thing is that you can take persisting sutures and close the cavity. Probably that would be much better option as it was done in the old days. And just one single comment that I've just missed the initial part of your talk, sorry. But I've seen that and I've done a number of cases. Hepatic cyst, which is in segment 7, just subdiaphragmatic, that can very easily be done by VATS. Just do a small phrenotomy and do it. And laparoscopically, it is very, very difficult and almost impossible to reach to that subdiaphragmatic area and doing.
So I'll tell you,
even if it is not ruptured, then also if it is not ruptured into the pleural cavity, then also probably VATS is much more easier as compared to laparoscopy.
And this pericys also helps in holding the tissue, and you approximate these balls very nicely.
Correct. So I think I agree with everybody's points. I'll tell you why I have done what I have done, and that is, so when you're learning in a medical college, and you have a lot of freedom, and you're under umbrella of someone. And I think, but when you're in a private practice, I think your practice should be covered up from all angles. I would prefer calling an HPB surgeon and let this job be done by him. Number one. Number two, I would have done it by once, but then I would have to go through the diaphragm. So I've done 3-4 of these kind of patients. So the fourth one landed up with a complication. But in the rest of the 3 ones, I think there was a lot of dense adhesions from the thoracic side over the diaphragm, and I just did not want to, go through that inflammatory area, and that was the sole reason why I avoided.
Okay, thank you, Dr. Shilpa, and we had a nice discussion. I would like to invite Dr. Amul Vanashali, fats for persistent air leaks.
Very good afternoon, everyone. Once again, special thanks to Dr. Kohli and team for the invitation and for the excellent organization and hospitality. Greetings from my home ground and the other hospitals where I work. So when it comes to air leak, it's always like, oh my God, there's an air leak, because a small air leak can sometimes cause disasters. So by definition, the standard definition of an prolonged air leak was the one lasting for more than 5 to 7 days. But I got this another definition from the STS database, which says this is for post-operative air leaks. This is the leak that typically present when the patient would otherwise be discharged if it were not for the continuous air leak. So this is what is a little more troublesome for us as surgeons. Types are peripheral, which is more commonly an alveolar air leak, and the central is what we call as a BPF, a bronchopleural fistula. Coming to the causes, so literature says that the most common cause for pulmonary air leaks and for BPFs is complications of bronchopulmonary procedures. Even they have reported lung biopsies having a significant incidence of air leaks. Post-lung resections, infections like TB and TB sequelae, bacterial, that is necrotizing pneumonia and so on, and fungal infections. Secondary spontaneous pneumothorax, thoracic trauma, and complications of mechanical ventilation. We all know this classification, the Surfolio classification of air leaks, and grade 1 to 4, I won't go through it once again. So coming to the management. First is, of course, conservative, wherein you keep, if there's no tube and you've diagnosed it, then of course you put in a tube first. But most of these cases, by the time they get referred to us, they already have a tube inside which is bubbling. So if the lung is gradually expanding with whatever measures that are already taken, or if you connect a negative suction or something and the lung is gradually expanding and the leak is coming down, then you can continue with only conservative management. Usually it is recommended to continue this up to 3 weeks of the chest tube, or even in post-operative cases up to 3 weeks after the surgery, you can wait for a spontaneous closure. Non-surgical options are to do only a fluoridesis, at time to do a blood patch, and there are also several bronchoscopic options like valves and so on. So these managements can also be tried for prolonged air leaks. And the third one is surgical. BTS guidelines say that every patient who has a prolonged air leak for more than 48 hours should be referred to a surgeon, but we all know that in practice that never happens. I wish closing an air leak was this simple, but unfortunately it's much more complicated. The challenges that we usually face are to do or not do. So first thing is whether should I take this patient up for surgery or should I wait? Is this the right time? Is the patient optimized enough? Then what surgical option to choose for? Should we suture? Should I staple? Should I put a patch? Or then can it be done by VATS, wedge resection or something like that? Or an anatomical resection? Or I might have to convert to open. So that's always a dilemma as to what option to choose. And then some of these cases, or most of these rather, also have a collapsed lung along with the air leak. So after whatever we do, will the lung completely re-expand? So we have to assess the lung parenchyma. And then after doing everything, it's still sometimes like, okay, have I done enough, and will the leak permanently close and will the lung fully expand? So these decisions are usually taken together by the pulmonologist, surgeons and anesthetists regarding the optimization and the timing of surgery. The principles for closure, first thing is, of course, you have to make sure that enough antibiotics, sensitive antibiotics are given for pleural sterilization. Complete drainage of the pleural space with an adequate sized tube. While planning your surgery, try and preserve blood supply to the chest wall muscles, because if there is a residual space or even to close the air leak, you might need chest wall muscles like either the serratus anterior or the latissimus dorsi to use as flaps to fill the space and to close the leak. Wide debridement and removal of all granulation tissue is important, and then identification and closure of the leak. Coming to a few case scenarios in which I have tried to do these by VATS. This was a COVID patient who developed a spontaneous pneumothorax while being on ventilator, and he got weaned off but became oxygen dependent, and the pneumothorax prolonged in spite of negative suction. The lung stayed collapsed and there was a continuous leak for a pretty long time. So this is a video. I will, in some time, I just forward the decortication part because it's same as any decortication. I've shown decortications videos in the morning talk. But this was the CT scan before and after applying negative suction. And once we went in, this was the picture. So it was actually already an empyema. And that was identification of the air leak. So that's the leak confirmed on an underwater leak test. That's the site of the leak confirmed. Now the first step was to completely mobilize the lung. So this is pretty much same as any standard decortication. So I'll just forward this a little bit in the interest of time. So that's mobilization of the lung followed by complete peeling of the visceral cortex. Now once the visceral decortication was complete, now was the time to decide what to do next. That's the leak and that's the unhealthy lung. So I'm sorry. Yeah. So one option was to do a wedge resection, but this gentleman would have lost a significant amount of lung parenchyma. So considering a COVID lung, we decided let's take only sutures. So there were sutures taken with 20 PDS. Luckily the leak stopped on table, and then I did an abrasion pleurodesis. You can see the lung didn't expand that well on table, but after connecting negative suction, this was the X-ray on discharge. I had to discharge him with the tube because there was still little bit of an air leak. But in 3 weeks we could remove the ICD, and this is the X-ray 2 months after surgery. So he did well. This is a second case, a 68-year-old gentleman, smoker, COPD, was transferred on NIV and inotropic support from another hospital with a grade 3 air leak. No improvement on negative suction, right loculated pneumothorax on CT. While he was being optimized for surgery, he needed to be intubated, and then he was taken up for VATS with a high risk consent. So here, that's the X-ray, that's the CT scan. So you can see even the underlying lung is quite bad. That was the picture on going in. and that's the site of the leak. Now here you can see this is a pretty big rent, probably caused due to the ICD or what, I don't know, but that was a quite a sizable rent in the lung. Now here again, after the complete mobilization, I've skipped that part of the video here, I've edited it out. After debridement, what I had to do is, now this part of the lung you can see is quite necrotic, it's all unhealthy. So I took that out, that's the leak. And here again, the only difference was that, again I have done suturing, but this is figure of 8 sutures interrupted, and before closing the last suture, what we did was place a strip of extracellular matrix into the cavity just to cause more granulation tissue or more fibrosis formation within the cavity. So you can, and this is doing with a small utility port and one camera port. So that's how this is being done. So keep the sutures figure of 8, keep them loose, or you can even take horizontal mattress and then keep them loose and then go on tightening them one by one. So these are interrupted sutures, and this, now there were small leaks still seen from the suture side, so that's why we put some glue onto that. And this also worked. This patient also needed a tube for nearly 2.5 weeks after the surgery, but eventually the leak stopped and the lung completely expanded. That's the post-op X-ray. The next case is a 74-year-old gentleman. ICD inserted a month ago for pneumothorax, which progressed to hydropneumo and surgical emphysema in this case. Now this patient was unfit for GA, so he was taken up for non-intubated VATS. This was done under plain thoracic epidural with only sedation. So this patient had a really poor pulmonary function test, so GA was impossible. Here again, after going in with, after the initial debridement, I'll just forward this. Yeah, there were these few adhesions at the apex which were taken down, and then we did an underwater leak test. So we could see an active air leak from the apical region, and here what we could do is, since this was near the apex, I could actually manage to get that part of the lung and use a 60 green and staple it off. So a wedge resection did help here. So that's the wedge resection, and then again followed by an abrasion pleurodesis, which again worked well. Now this post-op X-ray didn't look that great, but eventually the lung expanded. At least the leak stopped and the emphysema went off. The X-ray didn't look that great even later on. This is another 86-year-old gentleman, again a smoker, COPD with large bilateral emphysematous bullae. These are like, you know, isme kya karne ka, that kind of cases. I requested the intervention pulmonologist just try endobronchial if you can do something, because this patient was again difficult to manage. Now here, this was actually an iatrogenic problem. So the ICD had gone right into the lung parenchyma. So the ICD was taken out and a pigtail was inserted. So the ICD hole remained open. And so it was bubbling like anything, plus massive surgical emphysema. The patient's like, you know, his eyes could barely be seen. This was the case that the patient when he came to us. So this is a tube. So the tube, and they reinserted the ICD. So now there's a pigtail which is in the thoracic cavity, and there's an ICD which is into the lung parenchyma. So under vision, this, just give me a minute more. So this ICD was taken out, the pigtail was taken out under vision, and then after a little bit of adhesiolisis, here again this could be sutured. Now here I would have ideally liked to mobilize the entire lung, but the lung was so friable that I was like, let me at least close the leak and do minimum. This was again non-intubated VATS, some glue over it, and this also luckily worked. So this is the entire emphysema went off. That's the patient at 3rd day post-op. So, and this is the last case, there's no video here. This is here we had started with VATS but then converted to open. This is a post-lobectomy BPF. So lobectomy plus S6 segmentectomy was done for an aspergilloma. And after 10 months it developed a BPF. So here again it started with VATS but there were dense adhesions, so converted to open, and we did a intercostal muscle flap. So again, there are so many choices: suturing, stapling, muscle flap, wedge resection, anatomical resection, and at times you have to convert to either a thoracostomy or even an open plastic. So the right choice at the right time, and then probably you can with some confidence say that yes, I can fix the air leak, and finally it's keep calm and pray hard. Thank you.
Thank you very much, Amol. Just a commentary. Very well presented, especially the knee VATS. I think this is one presenting which is eye-opening, because these are cases like surgeons who just dismiss them. And after seeing this video, I think most of us will be now fully charged, motivated to go for knee VATS. Thank you very much.
You just need a good anesthetist who is excellent at thoracic epidural and confident enough to, if need be, worst case scenario, put a tube in lateral position. So you need a good anesthetist only, then you can do these kind of cases by knee VATS.
I had one question. If there's an infected cavity, do you still want to close it or try to mobilize more or do a lobectomy or a complete stapling of that part? Because if you leave behind a cavity and close it, chances of that recurring will be high.
Yeah, so if it's a clear-cut cavity seen on the CT scan, then yes, the resection would be a better option. I agree with you.
Dr. Amol,
yes.
Just a suggestion that in 2 or 3 cases, what I have done that whenever you are in doubt that after closure whether the lung will expand or not, so what I did that I put my finger inside and close the hole with my finger and ask the anesthetist to inflate the lung. So once the hole is occluded by my finger, and if the lung is expanding, then there are chances that after closure it will expand.
Yes, sir.
So I've done it in one case of aspergilloma which was very sick, ruptured aspergilloma, and as soon as I put my finger there, the lung expanded. So I just closed it with the sutures, and luckily the patient came out. So that way you can decide on table whether the lung is likely to expand or not.
Very well.
In view of time, we will take the questions.
Just one last question. You've not mentioned tissue patch. Use of tissue patch in any
So
of
you
your
mean
angular leaks.
Yeah, so you mean a hemo patch or something like that?
Or a tissue patch. You know, it's a tissue
patch.
Like Dura patch?
Yes, it's also called as Dura patch.
Yeah, so I have not mentioned that because I have not done any of those cases by VATS. So I have not used those kind of patches much.
The only problem with the tissue patch is that it is, it's not very flexible. So first, during application, you have to first expand the lung at least 75% and then apply the patch. Probably then it will take care of it. Otherwise, if you apply it on a deflated lung, and when the lung will expand, it will stop the lung from expanding. But it is kind of Dura patch which is used during neurosurgery. So it is not very flexible and expanding type. So first you have to inflate the lung almost 75%, then apply the patch. You can do it open or VATS, both ways.
Just one point of concern, where there is an active air leak with a major bronchus, so I think non-intubated VATS should still be done because there's a chance of soiling in the opposite side. But for parenchymal leaks like the one you showed in the first 2-3 cases, but if it's a major leak like a bronchial stump and all, I think it's better to isolate.
Yeah, bronchial stump, of course, better to isolate. Knee VATS, I don't think would be a good idea there.
Oral empyema,
Yes.
it's not a good choice to do knee VATS. If you have an empyema. If you have an empyema, I think knee VATS is not a good choice.
One.
I think, sir.
There is no question.
I
but
use, for these sort of cases, I take the piece of pleura, expand the lung, and put the pleural patch on that with a rough side on the lung surface, and put a Fevikwik around it. Okay, just the ordinary Fevikwik. is very good and it works very well. And it takes care of your, non-expanded lung. Or, I mean, you can't apply it on a lung which is not expanded.
Sir,
Anything
you
will
see-
not survive inside that group.
one more.
It's only the outside which is unstable. So outside I put it in the spit ball for about 10-15 minutes, and then I use ordinary Fevikwik 5 rupees cost.
Sir, I've done this, but minus the Fevikwik, I've done this in 3 cases during COVID cases, but they were open cases.
Yes, one. That it is not a question, but one experience which we had, that one patient was being taken up for decardiation, and the patient came with emphysema on the right side. Then what happened? We tried mobilized the lung, and then we saw that there is only one right main bronchus was there, and other side was inside. It was so hard to mobilize the things. Then ultimately what we didn't do anything. Put the relative, this chest tube inside, and then kept it for about 1 week. The patient was alright, and he is still coming for follow-up. Without spontaneous rupture was there on the right side. No history of trauma.
Thank you, sir. We'll go to the next speaker now. Robotic assisted thymectomy, Dr. Manas will be presenting this.
Sir, good afternoon. Dr. Mishra could not be here because of some unfortunate incidents, so I'll be presenting on his behalf. Good afternoon, everyone. Today I'll be discussing about a case of robotic thymectomy, and based on that, we'll be discussing about the principles and concepts regarding robotic assisted thymectomy. So here we have a patient who is a 35-year-old male who had come from Kenya. He had previous admission for previous swellings over the neck since the past 6 months. He was diagnosed with a prevascular mass. Biopsy was done, which showed it has to be thymoma type AB. He had taken multiple opinions. Eventually, he was referred to multiple hospitals for the definitive treatment. So this is the X-ray of the patient that is within normal limits. It doesn't look any strange. This is a CT scan. We can see here there is a well-defined mass here that is abutting the left side sternum and the costal cartilages. There is no vascular involvement. There is no obvious calcification or necrotic patches that we could see here. So he was diagnosed as a case of thymoma, and he was planned for robotic thymectomy. So in Manipal, we are using Da Vinci X surgical systems for all cardiac robotic surgeries and for robotic thymomas. Generally, we do the patient through the left side. Patient underwent general anesthesia with a double lumen tube, and we use 30-degree up on the left side, and we keep the arms parallel to the body. We don't keep it over the head because of obvious brachial plexus injuries. And this is the normal surgical console that everybody knows, that the surgeon console is placed away from the subject. The robotic arm cart is placed at 45 degrees, and one thing that we must understand is that the surgical field must always be wrapped for a possible median sternotomy in case of any emergency situations. So coming to the approaches, both left and right side method is possible. We generally prefer the left side approach, although the right side can also be done, and it can be based on of course, the surgeon's preference and the anatomy of the client. So coming to the objective of a robotic assisted thymectomy, the key objective must be to attain a radical and block resection of all thymic tissue from one to the next phrenic nerve and from the inferior poles of the thyroid gland up to the diaphragm. So concerning the left-sided approach, the advantages that we see is the contralateral perineum is better visualized and is shielded inside its superior portion by the superior vena cava. There is also a greater distribution of the thymic gland and the mediastinal fat to the left side around the left phrenic nerve. People who are doing it from the right side, it has got a lesser, relatively easier learning curve because of better ergonomics that we can achieve from the right side. Also, obviously, because of the absence of the heart, and also there is optimal visualization of the venous confluence and the aortic groove. Coming to the port placements, in Manipal, we normally are doing the 3-port technique. The first incision is generally performed in the first intercostal space in the anterior axillary line. Once we put in this camera port, we insufflate with CO2 at a pressure of 4 to 8 millimeters of mercury to enlarge the operating space, and the other 2 ports are in the third intercostal space in the anterior axillary line and the fifth intercostal space in the mid-clavicular line. In case of female patients, we tend to do it in the mammary crease for the cosmetic purpose. In the right arm, we use a spatula endolist that serves as electric cautery. The left arm, we use the Cadre forceps, and scope normally we use 30 degrees up or down depending on whether we are visualizing the IMA or the pericardium. So coming to the surgical field, there is very important that it is limited by a triangle that we try to follow. The lateral borders are represented by the individual phrenic nerves that we do on that side. That is, the phrenic nerves will be posteriorly and the mammary vessels will be anteriorly. You can see from here, the base is by the pericardium and the apex is situated at the base of the. It is important to go as high as the base of the neck where the apex is. So coming to the surgical techniques, at the left pericardiophonic angle, we start the dissection inferiorly and it extends along the entire length of the anterior border of the phrenic nerve. And it is important to isolate the phrenic nerve in all cases and from all anterior mediastinal tissue and from the fat. Once this is done, the thymus, we start mobilizing the thymus upwards and separated from the pericardium. We go all the way up to the level of the aortic arch. So one thing that is very important in this is one effort should be made to not to disturb the capsular integrity and using a no-touch technique. So in the superior part of the mediastinum, the pleura is opened and between the phrenic nerve and the mammary vessels. Once this is done, we continue the dissection towards the base of the neck until the superior horns are found and separated by a blunt dissection from the inferior part of the thyroid. Over here, the superior horns are grasped and we pull it downwards. One thing that we have to see is the innominate veins will be here and we have to be careful about that. And the thymic veins that are mainly here can be clipped carefully and they can be divided. So once the dissection is done, the thymic tissues, the mediastinal fat and the fat tissue is radically dissected. The specimen is put in an endo bag and is taken out. And normally what we do is we increase the port incision by 2 to 3 centimeters medially and laterally, and we extract the specimen, put in a chest tube, and the normal closure is done. The patient is kept in ICU. So this is the video. Okay. This is where you start the dissection. Over the superior part here, the thymus was quite adherent to the superior pole of the lungs. That's why you see this kind of a messy field here. And this was the entire specimen. It's taken out. So this is the specimen, and generally we discharge the patients on the third post-operative day. The post-op course was uneventful. Here you can see there's a repeat CT scan that was done that showed there is no evidence of residual or recurrent mediastinal mass, and the biopsy report showed to be a thymic mass, feature size of thymoma type AB. And coming to the discussion part of robotic assisted thymomas, primary epithelial thymic tumors are discovered in approximately 50% of all anterior mediastinal masses, of which thymoma is the most common. The efficacy of surgery in managing thymic disease is contingent upon complete excision of all thymic and perithymic adipose tissue. But the acceptance of thoracoscopic resection of larger, more advanced thymomas have been limited by safety concerns and by possible oncologic compromise. So you can see this is the chart from STS database that shows that initially in 2009, this is the chart of United States, and you can extrapolate for our country. In 2009, the percent of people undergoing radical robotic thymectomy was 6.4%, whereas in 2019 it is almost like 44%. And we know that as compared to conventional thymectomies, robotic thymectomies provide multiple benefits, including shorter hospital stay, better cosmesis, pain-free period, and reduced blood loss. It also provides technical advantage to the surgeons because of endurance instrumentation, tremor filters, and autonomous control of a 3-dimensional camera. However, there is a lot, when you see the long-term data, there is still paucity regarding what people say is thymomas more than 4 centimeters, they have caution, and in that regard, it has been said that thymic tumor size has sometimes been a predominant marker to select patients for minimally invasive or open thymectomy. The earlier studies like by Toru Kimura had shown that thymomas up to 3 centimeters can be safely resected. Studies by Kimura and colleagues have demonstrated that if thymomas are more than 5 centimeters and robotic assisted thymectomies are planned for those patients, there will be increased risk of operative risk with a chance to breach the capsule. But what we feel is large size tumor should not be considered a contraindication to robotic thymectomy. Of course, if there is a vascular resection that is required, that becomes a technical challenge which needs to be considered when selecting patients for the robotic approach. And the considerations that we need to consider, the things we need to consider while taking a patient for robotic thymectomy are location in the anterior mediastinum, the existence of residual normal appearing thymic tissues, a distinct fat plane between the tumor and the vital organs, tumor encapsulation. There should be no mass compression effects like SVC syndromes, and it is desirable to have unilateral tumor predominance, particularly for tumors more than 3 centimeters. To summarize, thymomas are slow-growing tumors that can exhibit a long disease-free period. Post-op recovery is obviously associated with low morbidity and a very short hospital stay. High rate of complete R0 resection, that should be the goal, and that can be achieved with robotic thymectomy for patients with even large thymomas, and the results can be still comparable with those with smaller thymomas or with large thymomas that are done through an open procedure. And only constraint is the need for vascular resection remains a technical limitation for the robotic approach. Thank you so much.
Excellent talk. In view of time, I think we'll move to the next speaker. I invite Darlong sir to speak on VATS metasterectomy.
Good evening, dear chairpersons, and first of all, I'd like to thank the organizing committee, Dr. Kohli and team, for having me here again in Jammu once again. Today I'll be talking about VATS metastatectomy. This is a topic I think most of us are doing it quite very, maybe to some extent one or the other time. So I'll be basically covering on what are the indications and where do we stand presently. Start now. Greetings to you from Rajiv Gandhi Cancer Institute. So I'll be talking on VATS metastatectomy. So this is the evidence for metastatectomy we see. There are not much randomized trials. There is no randomized trials. Everything is very much selection bias. There is no comparative survival analysis. There's a lot of inconsistency in the reporting, and the follow-up period is quite variable. But in spite of all this, we're still using it with benefits in terms of overall survival. So this is the first meta-analysis, came in 1997. This is basically international registry of lung metastasis. This was what they found, that overall survival was 36% if you do a complete arterial resection at 5 years, and 10 years, 26%, 15 years, that to 22%. But if you do an incomplete dissection, the 5-year survival was 13% at 5 years, and just 7% at 10 years, and 15% at 7 years. This data shows that there is very much variability in selection. There's a lot of selection bias. Again, came document in 2019, expert consensus, where they found around 18 to 19 documents to say basically they favor doing metastatectomy in particular setting. And this is the latest in 2024, presented in JCO, when they analyzed all data till 2024 Jan, and about 44 meta-analysis and about 23,694 cases were analyzed, where they concluded that they had some benefit in terms of overall survival. So the principles of our metastatectomy we see, you need an arterial resection. You do it minimally invasive or mini thoracotomy. The idea is to get an arterial resection. And the DFI is very important. That's how the biology of disease determines. At least about 1 year is ideal. And they should have received some form of systemic therapy if they are responsive to it. Not that cases where don't respond to chemotherapy. If the DFI is more than 1 year, you can go ahead. And the idea is to preserve the lung parenchyma as much as possible, because you need to go in maybe not just once, twice, and thrice. And obviously in this setting, the tumor biology is the key. These are protocol we follow at Rajiv Gandhi. So most of these cases, all these cases go through MVT. We do a PET scan in all cases to rule out any extrathoracic disease, because lung should be the only site where you have the metastasis, not other sites. And a CT with 1 mm cut is the minimum that we need to have a look, so that we don't miss any lesions. Because whatever you see on the CT scan should be seen on intra-op and taken out, and maybe extra beyond that. So this is what we have a preoperative marking on pre-op. We determine whether nodules are on a particular segment, divided right and left. And this is a table. You can see here that I got a PACS here on table. There's my PACS system there, and I see it, I correlate it on table on the same time whether I'm taking out that particular nodule or not. So it's very important that the counts are matching, and I should be maybe ahead of it, not below the count. So we can go for a staple one, and nowadays we have got the laser system, the NDIAC laser LIMAX system. So the staple one, in our center we prefer using the 45 mm stapler, not a 60 mm, because the chest is a small cavity, and this gives us better area for movement and preserving the lung parenchyma also. This is just to show the video of a setup of a metastatectomy. This is the right side. Left side is also similar. Only thing is you need to go more behind because of the heart. So we mark the scapula, the nipple, and the xiphoid, because these are the levels which decides our incision. You can see here, this is about a 6 cm incision, just the size of my forewrist, which goes inside and palpate the chest cavity. And my port is basically along the mid-axillary or between the posterior axillary at the level of the xiphoid or below the xiphoid. So this is a VATS or hybrid approach from VATS metastatectomy. You can see here, that's how it looks like from outside. I'll see the widest rib space. I confirm it from outside, inside. I would like to be exactly along the fissure, oblique fissure. That's how my four hands are there. I'll split the serratus muscle and go into intercostal muscle. I cut the intercostal muscle, split the latissimus, and basically spread out the ribs. We don't cut the muscles, we spread out the ribs and cut the intercostal muscle. In this way, we have got a good length of intercostal space to put in our fingers and do a bimanual palpation, because we need to be sure that whatever you're seeing on CT scan should be taken out. This is how it looks like from the wound side. You put an wound protector, just seal up the wound, mobilize the ligament, take out all adhesions, because that's how you basically free the lung from the hilum, all sides, and then you bring it out for palpation. That suprahilum, then mediastinal side, you can see here, I fed all the hilum. So this helped me also take out the lymph nodes. These are important in case of colorectal cancers like RCC. So these are the cases where lymph nodes need to come out. So I just pull out the lower lobe, you can see here. This comes out easily in the port. So once you bring it out in the port, after you mobilize the inferior pyramidal ligament, you can basically palpate it very well outside on the chest wall. You get a thorough digital palpation of the chest or lower lobe, you can see here bimanual, and I can go inside also. That's how it looks like when you do it from the outside. I'm just palpating it. And if you put the port inside again, I'll just put one more Foster clamp, just hold the lung out and try and bring it out as much as possible. Fill it again, just try and confirm any nodule is there. If I missed anything, if it was there on the mapping, I will just try to feel it. That's the undersurface, diaphragmatic surface. You can see the inferior pyramidal ligament, inferior pulmonary vein, and that's a posterior surface. I can basically run my finger around it. So every place, my four fingers are able to go in, fill the nodule there. And that's the fissural area. From there on, I go up towards posteriorly. The upper lobe, that's the fissural area. I could feel some scarring nodule-like thing. I just missed it. In the interest of time, I'll just go ahead. So, 45 mm stapler is the one we use for stapling because the limited space that gives us a better place. So this is how it looks like in a stapled metastectomy. You just go in, put a stapler there. It looks very simple for a small single lesion. I could take it off with just one stapler, but that doesn't mean that all my lesions are going to be small and ideally situated at this particular site. So this again, this other case, you see I had to put about one stapler now, gone. I'd again put one more stapler, second stapler going in. And again I need to go for a third stapler because that's how the angulation of the stapler is there. So I am basically losing more lung parenchymal tissue when I'm using a stapler. And at that, just for jugaad, we use a Prolin suture. Next comes the Nd:YAG laser. This is basically, we recently started using it about 2-3 years back, and now we have got a machine with us. And this was our experience. We published it last year. The initial 10 cases we have done with a laser system, Nd:YAG laser system, from September 2022 to 23, 10 cases, initial report. And this was the histopathology about tumors, malignant phylloids, embryonal RMS, osteosarcoma, NOC rectum, MPNST. So they were all basically post-NSCT, post-chemotherapy, and they had undergone metastasis, bilateral or a staged manner. And if you see a DFI, most of them were beyond 22 months, 27 months, 41, 34, and 85 months. The one in the stars are basically redo. These are basically, we had to do a redo metastectomy after the first metastectomy, mainly for colorectals and RCCs. So in our study, we had resected about 102 nodules. Histopathology was proven positive in about 88 of the nodules, with 86.3% positivity rate and no 90 days mortality. So we are able to take out more extra nodal lung tissue and prove beyond doubt that they are truly negative in some cases. This is how it looks like Nd:YAG. So based on the location, you can basically just bring it out in the wound expander port side, just take it off. It seals the whole side. Sometimes you might have to open up the bronchus, a small part of the peripheral bronchus, so you need to underrun with the suture. So these are cases we call a buttonhole metastectomy. These are ideally located along the lower end, along the fissures. These are basically something more towards the periphery. If you're going to a stapler, you have to take a lot of big wedge of the lung tissue. In this case, you basically go in, take the whole chunk of tissue around it like a buttonhole and suture it from the sides. You can see here that's the tissue it's been taken out, and at the end of it, you just underrun with a 30 PDA suture on all the sides, and that's how it looks like. You basically preserve a lot of lung parenchymal tissue, in such case which have needed a lot of area of lung dissection. So that's how it looks like on table. Lung is well expanded, well preserved lung parenchyma, and that's a CT scan. I mean, done almost 6 months. You can see here, this is the area, Vascari area. So I conclude that in terms of metastasis, OS benefit is definitely there, and the place selection is very, very important. R0 resection is the thing to be done, and lung parenchyma preservation is very, very important. And with NDR laser, we have to do more of that. And with the advent of more better systemic agents, we are going to do more and more of pulmonary metastatic in the future. And laser is definitely one way to go ahead. I'll just show the video of the one where I will show you basically how easily I can go in, see the whole how we can palpate the whole lung tissue. I mean, I think I have 2 minutes. Right? Yeah. So this is how, I mean, this is the lower lobe. You can see I felt the whole of the lower lobe. Now this is the upper lobe. This is the.
अरे देखिए जरा भैया.
Anyway, since we have 1 minute, I'll just go again through that. I mean, it's less than a minute. So this is the external view. I'm basically seeing the side where I'm going to enter. So that's basically along the oblique fissure, and usually between the scapula, angular scapula, and the nipple. That's a side where the rib space is quite wide, so I can spread the rib as much as possible without basically breaking it. I've split the muscle, intercostal muscle. I've cut that, and see, that's how I extend it anteriorly and posteriorly. This way, I'm not going to basically break the ribs when I spread the chest wall. Because if I don't do this, if I try to do pure wax, I might be successful in a case where there's a single lesion on the CT scan. In that case, the chance of getting another nodule is quite less. But if you've got 2 nodules, 3 nodules, there are more chances of finding more nodules.